After and we separate that, go back and forth. Get from the session while they're getting set up. And then we're not going to do this presentation come back to service. And then we'll show you how to get that feed going on. Okay, sounds good. That'll be on Teams. Communicate better.
Good morning. We're going to get started in 5 minutes. Thank you. Good morning. We're going to get started in 5 minutes. Thank you.
To get started, right? To get started,
Yeah, that's all. Yeah. Yeah, that's all. Yeah.
I'm trying to keep my stuff. One more time.
Yeah, that's all. Yeah.
Go back to I'm trying to keep my stuff. One more time. Go back to I'm trying to keep my stuff.
Well, it seems that you are here. I thought you
Good morning, everyone. Welcome to day 2 of the Beebe Symposium. We're going to build on the insight from yesterday on all the AI and machine learning development in all 3 areas and go deeper into parallel sessions. In the auditorium here today, we're going to talk about the digital twin in the morning. In the afternoon, we're going to talk about ethics and bias. If you are interested on the multimodal AI and machine model, please go to room 120. And for the afternoon 120 section, we're going to talk about uncertainty quantification. So we'll keep the meeting basically the same. If you have questions for all the speakers, please use the same slide or the same QR code. Have a great day 2 of the symposium. I'll turn it over to the section chair. Please go to room 120. And for the afternoon 120.
So good morning, everyone. We're really excited to continue the great discussions that we've been having over the past day. And today we're going to delve into a focus session on digital twins this morning. As the planning committee discussed potential topics around the breakout sessions, we felt it was important to keep the conversation going on this particular topic in reflection of the Academy's recently published report that I had the fortune of and privilege of co-authoring on the foundational research gaps and future directions for digital twins. So we're going to look at sort of these foundational aspects and have a deeper discussion. We'll define what a digital twin is, which is a virtual representation of a natural, engineered, or social system, which holds immense promise in accelerating scientific discovery and revolutionizing industries. By generating a digital twin, AI could enable us to model different systems and even a patient's entire body with all the different integrated systems to help inform and predict treatment responses. But there's certainly a lot of work and gaps to fill in order for us to achieve this. So I'm going to hand over to Sylvain, my co-chair this morning. By generating a digital twin, AI could enable us to model different systems and even a patient's entire body.
As a former NASA, I can think of digital twin first as a physical twin in the Apollo missions in the 60s and 70s, and actually NASA adopted the term digital twin in 2010. So, and the digital twin is a critical tool for decision making that uses synergistic combination of models and data. The bidirectional interplay between models and data allows the digital twin with a dynamic nature that goes beyond what has been traditionally possible with modeling and simulation, We know that our speaker will help shed some of the way digital twins are being used in and around radiation sciences. So without further ado, let's welcome our first speaker, John Bang. That's quite unique. So the use case of digital twin are diverse and proliferating, and we're going to hear a lot about this today. We know that our speaker will help shed some of the way digital twins are being used in and around radiation sciences.
Good morning, everyone, and thanks for introduction. And today I'm going to talk about our work on digital twin and AI for precision medicine. So what is precision medicine? And there are many different definitions. Generally speaking, we can define that one genes, proteins, environment, and lifestyle information to diagnose or treat disease. Another popular definition basically says that precision medicine just basically targets the right patient with the right treatment at the right time. Really right here. So how is the AI changing the future of precision medicine? You can see that in the center, AI interact with the patient, physicians, and medical community and hospitals, all these things together. Around that circle, you will see that a spectrum of applications that AI can play a role here. AI empowered early detection of disease, real-time monitoring of patient health, identifying potential drug targets, identifying causal genes, hospital typic or athletic heterogeneity, and tenure roles for spectrum. So it's just several examples of AI, how AI changes the landscape of precision medicine. In my view, there are several major AI applications in medicine. First, we talk about you see a lot of literature publication about disease diagnosis and tenure roles for spectrum. It's just several examples of AI, how AI changes the landscape of precision medicine. In my view, there are several major AI applications in medicine. First, we talk about you see a lot of literature publication about disease diagnosis and tenure roles for spectrum. It's just several examples of AI, how AI changes the landscape of precision medicine. In my view, there are several major
generate text, drafting the findings. And it can also do things like you might ask a prompt like, where is the pleural effusion in this image? And it can sort of generate a response saying, oh, it's in the left lung base. And it can sort of visually highlight that in an image. And again, like these are very impressive capabilities, but the question is like, how do we translate these successfully into the current radiology workflows? And just to give a very brief overview of the radiology workflow, I'm sure many people are familiar here. But typically you have a referring clinician who asks for a patient image to be taken, and then that image goes to a radiologist who examines that image, and they describe their findings and their impression or sort of conclusion. So here in this image you see that's just a large left pleural effusion, that's their impression. And basically this report goes back to the referring clinician who uses that to sort of inform patient care and treatment. They describe their findings and their impression or sort of conclusions. So coming from this sort of perspective, the question is, what are some clinically relevant use cases for these vision language models capabilities in radiology? And whether, how, and in sort of what form can we sort of put these, design these use cases to sort of provide value to radiologists and clinicians? So we conducted a 3-phase study. In the first phase, we just generated as many use cases as we can, and we took some of these to sort of further develop as prototypes. And then we did a preliminary evaluation with radiologists and clinicians to understand issues around user acceptance. And this is how our brainstorming sessions look like. Basically, within our team, we had clinicians and radiologists, and we were sort of going through several AI capabilities, thinking of like, AI can summarize things. Can you think of a place where this capability can be useful for you? And doing that, we were able to identify many use cases, and we sort of quickly created these user interfaces just to sort of think about like in what form that capability might be actually integrated into the current workflows. So we took 4 of these use cases that we thought were really promising. These were draft report generation, visual search and querying, augmented report review with sort of like a chatbot functionality, and patient imaging history highlights. So I'll go over a couple of these and just share what we've learned sort of building these prototypes. Okay, so the first one is draft report generation. Basically the idea is, can we provide radiologists with a draft report that is generated by AI? Like, would that be helpful? But here the challenge is really around the current workflow. So radiologists don't type reports, they actually speak, and that gets sort of transcribed into text, again by AI. And sometimes they have errors in that speech to text, but they really don't have time to sort of go back and like edit those like incorrect transcriptions. They have to sort of work really fast because there are so many images waiting to be reported. So they look at an image, they speak, and sort of stuff gets transcribed, and they move on to the next one. So what we thought was like, if we give radiologists like a fully written report, that might be difficult for them to actually go and edit them. So can we provide bullet points instead for findings? So the idea was that radiologists can sort of quickly review these, just go over them, add something if it's missing or like cross something out, and the bullet points then would sort of get translated into a full text. So that was the idea. And when we showed this to the radiologists, basically they thought the value behind this would be just like time savings and also saving some cognitive effort. And they thought this would be useful, especially for like multi-slice images, like complex images that are sometimes outside of their specialty. But then another question we asked was, how well does this system need to perform to be useful for you? So say you have like 10 images. Out of 10 images, how many are you willing but it also requires a really high accuracy or performance, almost like near perfect AI. And we thought, okay, this is really important to know. The other interesting finding we had was around this idea of like, oh, should we have bullet points or like full sentences? And interestingly, many of the radiologists we talked to, they sort of talked about this idea of standardized reporting. So they said, oh, we actually think in bullet points. So maybe like we can have them sort of next to each other and we can like edit the bullet points and then that can sort of translate it into sentences in real time. But basically they were sort of discussing this idea of like this, oh, this narrative report is kind of old and it has a lot of like hedging language. So we don't need to sort of reproduce that with new technology. And we thought that was also like really interesting. Okay, and the final thing I want to share is sort of starting this work, we were thinking, oh, like maybe if we have a set of findings, we can generate reproduce that with new technology. Versus the impression section, they seem to really care about the impression section more, and that seemed sort of harder to get right. So they really wanted to have control over that section. So we thought, okay, maybe the impression section is not the great place to put AI into, at least to start with. So maybe AI can actually start with findings and radiologists can have more control over the impression section, which seemed really the sort of communicative piece between the clinician and the radiologist. Okay, one of the ideas we were sort of curious about was, okay, this is for radiologists, but what if clinicians had access to this AI-generated report? Would radiologists feel like threatened by this? Would they feel they're sort of being taken out of the loop? And interestingly, radiologists thought that it would be okay to show this as long as it's clear that this is just a preliminary report. It's a wet read. And they thought it could be actually useful for triage so that a clinician can sort of escalate these cases where they think like something is suspicious to sort of communicate with the radiologist. So we thought, again, this is a good sort of use case for prioritizing some of these images. All right, moving on to another use case. So this was around providing clinicians with more like easy to read reports. So AI can basically sort of localize some of these findings in the image so that clinicians can sort of go through this, especially for like complex images, not 2D, but maybe like 3D. And the other idea we sort of explored in this application was this AI assistant that clinicians can sort of like chat with. So maybe asking like, what are the clinical guidelines for this? Or things like that. So basically we thought, okay, maybe the clinician can like enter some prompts and the AI assistant can pull some relevant clinical guidelines or similar information. So we've also sort of explored having this sort of information nuggets instead of a chatbot interface. And one of the things that clinicians thought about this was, oh, like we really want tool-based interactions over a chatbot. So this shouldn't be really surprising, but clinicians are extremely busy. So they were like, I don't have time to talk to a computer. I want tool-based interactions. And I think this is a key insight because today, many of the applications we see around LLMs are just like thinking of these as chatbots. The other interesting insight we had was we were thinking about like what kind of information would be useful for a clinician. And clinicians really thought, okay, like I don't want generic information. Like I don't need to see the 10 most like common causes of a pleural effusion. But if you can combine this image information with the EHR data and tell me like, normally you wouldn't consider this cause, but because this patient has this XYZ, this thing should be in your like top 5 consideration set. So they were really interested in very like patient-specific contextual information. And again, I think that really motivates the multimodal aspect in healthcare because there's only so much you can tell from images. And the other interesting thing was when we were showing this, so some of this is around like giving information about radiology, and some of this is really like clinical information. So some of our participants were really sort of confused about like, wait, is this a radiology assistant or is this a clinical assistant? So these should be sort of separate in different interfaces or in different systems we use. So we really saw that there's this expectation of a workflow-specific assistance rather than having this sort of generalist AI that can sort of answer any kind of question. All right, I'll share one more use case that we explored, and this was around providing clinicians and radiologists with some patient imaging history highlights. So something that both clinicians and radiologists do is they sort of look through a patient's past images and reports to see like what was there before, what changed, and just sort of can we get a sense of what was going on. And they spend a lot of time sort of going through each of the report, like click open it, view what was there, maybe it wasn't relevant, go to another report. So the idea was really simple. Can AI sort of go through these past reports and images and just give a few like brief highlights? So saying things like, oh, like this patient had this many imaging studies in the past this many years. The left lung nodule increased in size from like this millimeters to this. And there's something in the like chronic nodule. This is benign. It was in a past imaging study. Here's a link. You can look at this previous study. So really highlighting the key events in that patient's history. And when we show this concept, both clinicians and radiologists thought that was a really sort of good use case because they spent a lot of time doing this. And what they shared was like, okay, you don't have to have a full perfect summary. Having like a good enough summary is better than nothing. And we really like this idea of like, oh, AI doesn't have to be perfect, but it can be still useful. Because the reality of these systems is most of the time, they're going to make mistakes. There's always this uncertainty. So we were really thinking of this, like, as opposed to the draft report generation, right, which is AI has to be really, really good to actually be useful. This is relatively like a low-hanging fruit where it's like relatively less risky. Okay, I want to highlight a couple of key takeaways from this work. So the first one is I think there's a really good opportunity to sort of reimagine what future radiology reporting looks like. I really like this cartoon that says, oh, like AI turns this single bullet point into a long email I can pretend I wrote. And the person on the other end is like, oh, look at AI makes this single bullet point out of this long email I can pretend I read. So we really need to sort of think carefully about how do we present these AI outputs, in what form? Do we sort of prioritize these? Is this like short form, long form? So the interface and the interaction of the actual application here becomes really important because, again, at the end of the day, if radiologists are spending more time on working with an AI-generated report than they currently do today, like they're not going to use it, right? So that's the first point I wanted to make. The second one is really this sort of thinking about this like generalist versus task-specific AI. So I think currently the AI research literature really thinks about this problem as like, oh, can we build this sort of one model that can do everything? But if you think of how clinicians perceive this, their mental model is more about like, okay, what does this specific model do? What's the data it's trained on? What are the specific capabilities of this? What are the limitations? So we need to sort of find a way to communicate that to the clinicians as they use these systems. Because if they don't have this sort of proper mental model of like how these things work, they're not going to trust the system. The other sort of key thing I want to highlight is we really need to sort of start moving beyond this common paradigm of like chatbots. So currently, most of the, again, LLM systems, they're sort of designed as chatbot interfaces. And that can be fine for some like consumer-facing applications, or maybe some of the sort of patient-facing applications in healthcare, but it really might not be the best sort of interaction modality for clinician-facing applications. Message of my talk is really developing AI applications in healthcare is super risky, right? There's a huge failure rate, and the idea is like, how do we reduce this failure rate? And I think one good approach is to take this sort of human-centered innovation where you're sort of engaging clinical stakeholders throughout the process, starting from like choosing the use cases and then designing and like refining these applications together, selecting the data sources, and all basically involving clinical stakeholders all throughout the process. And in yesterday's opening session, there was a lot of discussion on like the difficulty of actually creating the implementation. And my experience working on healthcare AI systems has been really similar. So I think we really need to think carefully about like, when does the clinician see this AI output? Where do they see it? In what form? And what kind of action do they take using that insight or that prediction? And not just thinking about just like a single role. Most of the time we think, oh, there's a single clinician using a single interface, but healthcare is really complex. So we need to actually think about several different roles and the whole care team working together to actually deliver patient care. And finally, this idea of like low-hanging fruit, right? Trying to find, so most of the time we think of these sort of moonshot use cases that are really sort of research worthy and hard. But there are some use cases that are like relatively lower risk, maybe not around clinical decision making or patient care, but things around like fetching some information and like presenting in a more sort of consumable way. So I think a lot about this idea of like, what is the low-hanging fruit where AI doesn't have to be perfect, but having something can be better than nothing. All right, before I wrap up, I just want to briefly mention some of my ongoing work. So we're currently building on this work that I just shared at UVA to explore this sort of unique data set of hyperlinked image report data. So typically in radiology, the reports and images are not connected. And the way people currently work with these is just like going back and labeling these data basically manually, like how each sort of finding corresponds to like what section, what region in the image. And UVA is an interesting place. So they have this interactive reporting system that they've been using for the past 10 years or so. And this lets basically clinicians, radiologists, to actually like select a region and select the corresponding finding. And that sort of creates a hyperlink that clinicians can sort of click on that and see where that finding is in the image. And basically, what they've been doing is they've been creating this really high quality data set. And currently, we're sort of exploring, okay, what might be some AI opportunities for some downstream applications for this data set. And again, I think that sort of comes back to this question of like, how do we create these kind of tools and infrastructure that sort of lets clinicians create really like high quality data sets in the first place? Because today, most of the data that is created in healthcare is really created for billing purposes, and it's really like low quality, hard to work with. So I think a lot about this issue of like data quality and building data sets with some like downstream applications in mind. Okay, with that, I'll wrap up. I'm happy to take questions during the panel section. Thank you so much.
Great, thanks. We're on time. The next speaker would be Jia Wu from MD Anderson Cancer Center, and he'll be talking about radiomics applications and combinations with omics data to stratify patients for immune checkpoint inhibitor therapy in lung cancer.
Right. Good morning, everyone. It's a great honor to be here and share some of the work we have done to continue the discussion for how to leverage AI and multi-modal modeling in cancer. So today I'm going to show you a couple of the study cases we have done in this field, primarily focused on lung cancer. This is my COI. And just a very brief introduction of the background. I think everybody here has already been, feeding this information multiple times. So the precision oncology actually is, how can we deliver the right drug to the right population at the right time using the right dose? And there's a tremendous amount of the data here accumulated, and not just imaging, but also the tissue-based, the blood-based markers. And classically, there's very, very limited amount of the biomarkers have been used to given the treatment to these patients. And through my other connection with a medical oncology department, I'm surprising to find out when they treat the patients, there's a lot of gray zone. So that means you can treat either A or B or C, where they have no clue how to do that. So today, the first study I'm going to show you is how we can leverage this multimodal data, try to address a rising clinical challenge here. So in this first study, where we have carried the first clinical trial to show adding immunotherapy to radiation, especially the SBRT treatment in early stage lung cancer, can significantly improve the patient's outcome during our reported ICBAR cohort, ICBAR trial here. And strikingly, in another late stage cancer, in another late stage phase 3 trial, where they find out exactly the same settings, but the treatment is negative. And here, very naturally, the question is why? And why, similar, strategy in our population works, but in another population seems not working. So this, when we discuss with the clinician, this raises a question, how do we select the patients? Maybe it indicating not every patient will benefit from this treatment. So what we have done is by designing these, leveraging this clinical ready data, using the imaging, using their clinical factors, try to build a predictive modeling framework, try to guide the patient selection here. So I will not have the time to go through these details, but I can show you some of the high level concept here. So for this study, for this ICBAR trial, we have privilege to get access to this data. We first download all the patient's pre-treatment scans, and then we go over this scan, meticulously segment out the tumor, get the blood vessel segmented, and then we extract all these features to quantify the tumor, the background parenchymal, and the blood vessels. And then we go through this human AI and how robust all these features looks like, and is there any correlation for these features? We go through all these details there. Then once we have checked out the quality of all these features, we add in the clinical factors inside. The clinical factor including all these standard, age, gender, performance score, all these, standard clinical factors here. Then we go through this modeling process in step 2. So in a very high level, what we have done here is we build two predictive modeling based on the two arms. And then we can do the counterfactual analysis to see what if I switch the patients off this treatment and give the patients another treatment. And by applying this, we can calculate the individualized treatment effects. And then we could start to use this to guide the patient's stratification. And then we compare our AI or machine learning guided patient stratification with the random stratification and show does that have any concordance or is there any observed clinical benefit by doing that. And then we try to validate this model, but unfortunately there's no other data available for us because we published this first trial. The other trials are negative. They don't even have their results published yet. So here I'm going to show you more details here. By applying this model here, so this dotted line shows, what if the model switch, don't use the real treatment. And here, as you can see, where for the patients who receive the first subfigure A shows the patient receive IC bar, meaning adding immunotherapy to that. But the model are able to identify this subgroup of the population, which seems not really benefit. And on the other B figures where you can see the patients receive only the radiation treatment without adding immunotherapy, where you can see there's actually this dotted line here. We identify the patients may benefit from adding immunotherapy to their treatment. And here we plot out all these 140 patients in this two treatment arm. And strikingly, as you can see, there's a large amount of the population of patients by AI predict they should switch to the other treatment rather than stick to their original treatment. And by doing that, we can observe there's clinical benefit by doing that. And then the last thing we try to address, spend quite a lot of time try to work with the clinicians, understand what the AI model really sees, some signals where the clinician may fail to observe. So we look at the blood vessel, we look at the tumor, the intensity, the surrounding tumor areas, and we run this Shapley value analysis and start to look into some of these individual features. How do they link to the clinical stratification, and find out there's some trend there in these right side figures here. I will not go to the detail here. And later we have, feed this information back to our radiation oncologist and tell him, look, this is what the AI model try to predict. And given you have this knowledge and you go back to the scan, are you able to maybe agree or disagree with the AI modeling? And strikingly, the radiation oncologist, this all top-notch radiation oncologists we collaborated with, they have no clue, how to observe this information. And so that's that's something even, we try to, hypothesis, maybe that's, the more features they can only, if we tell them, hey, how large is the tumor, they can do it. But we tell them, hey, this should be the blood vessel X, and tumor size Y and background Z. And when the dimension increase, they start to lose the track, how to really quantify these patients. And also they, and then we ask them to do another task is saying, let's forget about AI, just show you these patients where AI stratify them, adding or not adding immunotherapy. Can you tell the difference by looking at just imaging? And they fail to see any clinical or radiology patterns by just looking through their eyes. So this even, shows maybe there's something, we need to, of course, further validate this. And then another thing is maybe shows AI can really quantify something if this is truly some signal here, that indicating the question we discussed yesterday, how this interpretability should be applied into understanding these AI models. And here we are even not applying the black box model. All these features are interpretable here. And here we also benchmark our model on these individual features, such as just a tumor size, just as one of these top selected features. And we find out that the stratification actually not reach this complexity of this interaction between all these features selected. So here, the next study I want to show is where we apply the similar strategy and to address a medical oncology problem. So here the challenge is, in the late stage lung cancer patients, when they go walk into the door of the medical oncologist, currently if they don't have the driver gene mutation, the standard treatment right now is immunotherapy. And of course, now people start to adding more things to the immunotherapy, like chemotherapy or dual immunotherapy. But strikingly, as we talk to them, there's no clue how do they guide them to adding or not adding, or intensify, and how long this treatment should continue. So what we have done here is by carry a multi-center collaboration with Mayo Clinic, Stand Up to Cancer, and also Dana-Farber to curate this largest real-world data, and this including the clinical genomic data we can get access to, and try to do some counterfactual analysis here and to address this question and to see if there's any signals we can tease out from these existing clinical genomic factors, which is not like this next generation gene sequence. It's just this gene panel mutation available to the clinicians. And here we have show, the last row here shows the negative, the better, actually, just want to indicate here. So that we have built 5 models, and then as we observed, any of these models have a lot of uncertainty associated with this model. And when the model, maybe A model or B model, when we show them on different data cohort, actually their performance fluctuate. So a strategy we actually adopt here is try to kind of let them voting or let them starting, adding some very simple idea to, to quantify this uncertainty and take this into consideration and to address the prediction. And by just simply doing that without any fancy, like the deep learning black box, and we can make this model significantly improved. So that is, maybe another lesson we learned here is actually, no model maybe is perfect. And in reality, maybe every model is also different. If you just tweak this model by using a different maybe optimizer or different feature selector here, that can give you a very different prediction. And when you combine this model together, actually that can maybe reach the optimal performance down the road. So here by applying this model, we can better stratify these patients' progression-free survival. This is indicating there's always a group of the patients this model can select, which shows they may not benefit the treatment they have been assigned to, and they might be benefit by switching to the other treatment. And also we do the interpretation here, and since it's so high dimensional data, we look at the mutation landscape, look at these clinical factors, and to see how does that associate with the patient stratification by adding the immunotherapy to their adding the chemotherapy to their immunotherapy or not adding that. And here, I want to also, since this is a multimodal panel here we are discuss, I want to show you some of the feature directions and some of this, work we have done in this field. As we, already know, there's for cancer, treating the cancer right now. So sitting there on on these computers, scattered different system, we have the patient's radiology scans, their digital pathology slides, their molecular data, and also some clinical notes. And here, beyond, we just look at one of these omics data, and the pathway is how do we really integrate them together? And the first challenge for the imaging, actually, it's not structured data. How do you meaningfully extract the features? There's no agreement right now. There's foundation model going on. There's, some classic way to extract the features. And it's not like genomic data, which is already structured data, where you could just ready we can call that AI-ready data to directly apply whatever machine learning algorithm you want. And here the first step is for certain modalities. How do you represent this feature? How do you represent these features or profiling these patients out of this data? And if you want to do this clinical interpretable way, actually it's very expensive. You need to annotate the scan meaningfully. And if you look at the pathology, you need to annotate maybe these regions comprehensively. And then the next thing is how is there a correlation among these different modalities? And the next thing is how can we align this? So align here, meaning, so I think we already discussed that here, the many discussion there. For me, I think the concept is very simple. It's like, when you look at the computer vision problem, there's a dog there, you look at the image, you look at the text, you hear the word, it's all meaning the same thing. And here, no matter what, no matter what platform you are looking at, it's all the same patients, same tumor. So if we just take a very simple example, what does the immune hot or cold tumor really mean from genomic? How do that propagate to pathology level? How does that show at these, CT scan or PET scan or MRI scan? And after that, once we have all these teased out, sorted out, we could start to meaningfully integrate them and to address some, real clinical gaps and bring this hopefully one day to the clinical problem. So here I want to show you some of the efforts we have done in these different, aspects and also integrate them together. So this is a study we published a few years ago where we apply here. We don't use these, interpretable radiomic study where we're throwing the black box deep learning here and on our MD Anderson cohort and to look at the chest CT scan and the clinical problem here is end-to-end predict the benefit from the immunotherapy. And we have, trained the model and rigorously validate this model. And also we embedding this imaging model into the clinical context to see, what is there any added value to this existing, such as PD-L1 measurement, such as these metastatic patterns already being observed by this radiologist, or is there any, any added value here? And we observe there is, some added value here to stratify the patients. And then we externally validate this on the Stanford data. And beyond that, we have correlate our model with the radiogenomics pipeline where we have certain patients have their genomic markers, we have their blood measurement here, we correlate and try to understand what this imaging model try to look at. And here are some example here to show you, and this different color meaning the training, validation, and testing. The top row is predicting the OS, the bottom is the progression-free survival. And we benchmark our deep learning CT model with the PD-L1, the tumor volume, the handcraft radiomics features, as well as the benchmark model. And surprisingly, as you can find out, the deep learning look at the CT scan, not necessarily beat the benchmark model. The benchmark model is what's already been there in the EPIC system, where we have medical oncologist fellow meticulously collecting all this data from the EPIC system and give us to build this model. And so that benchmark model, including all the radiology, pathology, genomic factors, the best model, the knowledge model they have known. And then the value here we have shown is by adding the deep learning CT model on top of this benchmark model, we can further improve the prediction here down the road. And also, I think another thing I want to highlight is another study to indicating just how bringing some new hypotheses to this existing data, or maybe changing the way we look at this data can give another additional information. So here we call this habitat imaging. So as people talking about the cancer, compare with all the other disease we study, the cancer just itself is very heterogeneous within the tumor, and we are starting to look at even the single cell level data right now. And so if we look at how conventionally how these imaging features are extracted, it's all look at just do the ROI and then extract the radiomics feature, or you can apply the deep learning, and hopefully deep learning will automatically take care of this intratumor heterogeneity But here we just apply a very simple habitat imaging idea. By clustering, we apply this two-step clustering idea to just clustering these pixels by aligning this multimodal data here and clustering all this on the population level, and then mapping this population level cluster back to the scan, where you can find out there's giving you this intratumor heterogeneity map. We call that habitat map, and this is very similar to the current genomic study, where if you look at a conventional radiomic study, is you just segment the ROI and do a bulk sequence. Hopefully you could get signal out of that. There's some signal there, but maybe not as strong as you wish. And then, then people can start to look at like the histogram, look at the whatever things within the tumor, like the single cell study, but you lose the spatial, where that signal coming from. So, from the imaging sitting there, by just simply apply this idea, we could, maybe, just adding some knowledge here, we can, boost the prediction here. So in a recent study, we have shown by just applying this idea to the PET-CT scan, and, for these patients' pre-treatment scans, and we can identify these patients, stratify them into this high, intermediate, and low risk population, where they have very different risk after their surgery for the cancer recurrence. And also, very interestingly, we have we have access for this circulate tumor DNA data, and we combining this imaging data on top of this circulate tumor DNA data, we can further boost. There's some correlation there, but they are not identical. And also we do some radiogenomic analysis, try to correlate to see, hey, what's the imaging phenotype and genomic pathway, how do they correlate? We find that, through 3 different data sets, we find out some very consistent findings. So this indicating the prior, like mechanism design there. We want to understand how does this molecular really propagate at the different levels. So these some efforts we have spent, but of course it's just a baby step forward, and now we are collecting more data and push this forward. And another study I want to highlight is just the imaging itself is already multimodal, because we have the CT, which is anatomical. We have the PET, which is functional. And there's more molecular data out there, molecular imaging data out there, testing and enter the clinical practice. So here, we do a pilot study, try to understand, can we bring this power of the AI to predict a PET from CT scan? And here we run some pilot study. And here for this left side, you can see these are 2 sets for the totally validation cohort, where they're CT scan, the ground truth, and our predicted PET. How do they look like head by head? And then, not just we want to get these photorealistic CT scan, PET scans to us, we go through this imaging validation to validate how these imaging signals are similar from our synthetic PET versus a ground truth PET. And we ask 3 seasoned nuclear medicine radiologists and thoracic radiologists try to do a Turing test here. And later they find out short pass, because if you observe, if you look at this predicted PET carefully, you will find out they are more sharp. They don't have this kind of blurry things there because of the real PET. As you know, it takes more time to acquire. So that's always, there's kind of the blurry motion there, the noise there. But our predictive PET are much more sharper. So that's, that's a kind of a short pass they can cheat. And then, later, once we confirm, there's very, very high fidelities among these ground truth PET and also these synthetic PET. And the next thing we do is do the biological level validation. We have the genomic data. So we extract the radiomics features from our ground truth PET and also our predicted PET, and see are they point to correlate to the identical pathway. And yes, we find out there's very high correlation there. And beyond that, we start to do some pilot study to show does this synthetic PET really add any value to the clinical practice. And through this different clinical workflow like diagnostics, staging, cancer prediction, and prognostic. And we find out just a very simple features such as SUV max, extract from this PET. You could start boost your performance without even playing any machine learning on top of that. So, on the similar line, what do we have? Collaborate with Methodist cardiologist, where they approach us when they saw what we have published. They say they have a large amount of the cardiac PET sitting there. And, as someone in the field will know, the cardiac PET, which is very complex, expensive, and hard to analyze. And usually it's not that easy for patients to even to get it. Only this, top-notch place have it. And but on the other side, we have this EKG data, which is cheaper and everybody can get it. So, they want us to see, can we do some link between these two? So what we have done is take their EKG data, and then we try to predict this myocardial perfusion or myocardial blood flow, which is one of these strong prognostic factors. Once you get the cardiac PET, usually the cardiologist or the radiologist there will read this and tell if the patient are at high risk or low risk. So here, based on the data they share us, which we build a model and which have a AUC around 0.8, which is not that high, which is not maybe, that means there's still some information maybe not captured along this EKG data. So what we have done, when we present this to them, they don't trust us. They basically say, hey, this is AI model. We don't know what's going on. And so they ask us, can you give us a model and help us to install that in Methodist so we can run it on ourselves. We spent a couple months to teach them and bring that to their clinic. Then they throw in 17,000 in-house data through this model. So this is what this Kaplan-Meier curve shows here. And also, as you can see, they have this measurement, real measurement, and when our model predict, and you can see they almost sit on top of each other. And also the stratification are really, really good. So that's indicating, you may really not need a perfect model as you wish, like 0.99, 0.95. But sometimes if you have a model which, you are confident, and also if you have this engineer or clinician loop where you could do this fast testing here, there's a path. Maybe we can bring this model to clinical practice. And hopefully one day this model can even, make some clinical impact down the road. So here, beyond the imaging, the medical, the radiology, also we start to look into the pathology data, adding this to the picture of this multimodal, era we are trying to analyze. So this is a study we have, starting to wrap up, where we look at this whole slice imaging, where we collect from the lung cancer patients. And then, we run through some very, not like this foundation model, but we try to first, as you can see, we tile them into the different patches. And then we try to build a model, try to predict the different compartment. Are they tumor, are they stroma, immune vessel, based on the pathologist annotation. And we call that, we generate a map here. So once we have this map, we could ask, we have a checkpoint 1 here, where the pathologists help us to see if this AI really predict good quality or not a good quality. After all these scans or samples are passed through their quality check, we go ahead and take this segmentation map and build a deep learning based machine learning stratification to see the high risk and low risk patients. And here, I want to highlight is once we build the model on these pathomics data, and also we have the radiomics data on top of that. So we have shown here by adding the radiomics and also pathomics data and clinical data together, it can reach this optimal stratification here. So this indicating there's some, some signal there, maybe not propagate through other layers, but it's maybe unique to this modality. And another study I want to highlight is, go deeper into this tissue-based measurement. So here we collaborate with a group of the medical oncologists and these basic science. And when they approach us, they show us this large amount of these human samples where they do the top-notch spatial proteomics on top of these samples. And the question here for them is try to understand how this evolution from the normal to pre-cancer and to invasive cancer. And so we start to work with them and build a machine learning pipeline, try to segment out these different cells and try to phenotype and build a graph-based way to analyze this data to understand this tumor microenvironment evolution at a different stage. And then we find out actually on top of what we have known, we find out the TIM3, which is an immune checkpoint, and which is a potential inhibitable target. And here our clinician run the first of its kind immunoprevention lung cancer trials and already show some signal there by giving the immunotherapy drug to the pre-cancer. You can kind of intercept the lung cancer from developing into the invasive cancer. And here, by analyzing these, we find out actually not just the PD-L1, but TIM3 could be another very interesting, target to bring the drug. And here, once we shoot this paper out, the reviewer starts to ask us, can you add more evidence? So we actually go to the multimodal to beyond the human samples to look at the small animal and bring the drugs to the mouse and treat them at a different stage. And we show by inhibit that TIM3, we did show the tumor or pre-lesion start to shrink or stabilize or delay their progression to the invasive cancer. So here, this is, I believe this is my last scientific slides. So this is, just want to zoom out and hopefully I have, show you a couple of these efforts we have done at different front mixed with different data type to address a different clinical problem. But beyond that, there's a large amount of the data sitting there from the text, imaging to tissue to the fluid. And all this data, I believe, once we have access to that and we apply the meaningful analyze on top of this data, we can, use this data to address these clinical challenges. And with that, I would like to acknowledge my team who have done all this great work and my collaborator across the different department and beyond MD Anderson, and also our patients who willing to donate their tissue samples data for our analysis, and also these fundings and potential donors who support our research. Thank you so much.
Our next talk is to be given by Igor Shuryak from Columbia University. He'll be discussing the enrichment of the linear quadratic model, which has been the basis of radiation oncology for all these years, with omics data and using the techniques of machine learning, using causal random forest survival analysis. Igor.
Yes, good morning, everyone, and thank you very much to the organizers for inviting me. I'm very honored to be part of this symposium. And this work here is a collaboration between clinicians and researchers at Columbia University and also at Princess Margaret Hospital in Canada, and including the work of some young and talented students. So, of course, mathematical modeling with some mechanistic or semi-mechanistic principles has a very long history in radiation biology, radiation oncology. For example, linear quadratic model or some toxicity models. And such models are based on different types of data, not only human clinical data, but also animal experiments and in vitro experiments. But the drawback is that these models are simple and they include only a few inputs and cannot include this kind of rich type of data that is accumulating in electronic records. For example, demographics, of the patients, or disease details, or omics and imaging especially. But ML methods, of course, are able to integrate all of this, including multiple modalities. Somebody is moving this around. Okay, that's okay. Okay, thank you. So they can integrate these different modalities and multiple features, and usually can generate accurate predictions. But the drawback of this is this black box so-called phenomenon that interpretation is much more difficult compared to the simple models. So we thought it makes sense to integrate these two approaches together. And of course, it's not just us, it's many people thinking of this. And a very simple way to do it seems to be to take some concepts or outputs of the simple models, like something like biologically effective dose from an LQ model, and put that into the ML model context as an engineered feature of some type. And this feature can be easily interpretable, of course. And the idea is to improve interpretability and potentially can guide some insights for clinicians. And also, by incorporating these elements, the ML models can benefit from a broader knowledge base, not just limited to the current data set, especially if the data set has some limitations. It's small, or data quality may not be the best, and so on. So the example we present here is with head and neck cancer. It's with using tabular data, but we definitely want to extend this more to image data and other type of modalities. So for head and neck cancer, it's known for a long time, at least since 1980s, that repopulation of the tumor is important for radiotherapy outcomes, because the longer the radiotherapy course takes, the more time there is for tumor cells to repopulate. And this graph you see here is from the 1980s, from classic publication by Withers, which shows this. And the simple model that was developed to handle this can be called the hockey stick model, where it's assumed that accelerated repopulation starts at a fixed time, say around 28 days after radiotherapy begins, and then its rate is assumed to be independent of cell killing and constant. And this can be called a dose-independent model. And we were thinking how to improve this, potentially make it more biologically plausible, but still keep it simple. And one idea is that the repopulation is likely to be compensating for cell killing. So if the cell killing is more intense, for example, you're giving bigger doses per fraction per day, or maybe BID fractionation, something of that sort, the intensity of the killing will increase. So the repopulation onset time and rate may change as well. And this was the rationale for this dose-dependent modification. So we applied these two models, which are abbreviated as DI for dose-independent and DD for dose-dependent. We applied to various data sets like older clinical trials. And more recently, we used it on this more recent data set called RAD-Cure from Princess Margaret Hospital, which has a large number of patients, more than 2,600 with head and neck cancer. And it has a comprehensive database of radiotherapy details, of chemotherapy, clinical variables, and so on, and long-term mortality outcomes. And the bottom screenshots are some papers that we published on this. So in this RAD-Cure analysis, we use this approach to take the mechanistic concepts from those simple models and put them into a machine learning context. For prediction, we use the random survival forest kind of exploration and prediction of total mortality or cause-specific mortality. And then we used causal survival forest for focused causal analysis. So the BED versions for these two model variants differ. So in both cases, there is definitely a cell killing term, which was assumed to be the same, just given by the LQ model. But the repopulation term was treated differently. As you can see here, there are somewhat different assumptions and some simplifications to keep number of parameters low. And the parameters you see at the bottom, there is only 5 for both models, actually, and they're pretty easily interpretable. Like, of course, alpha beta ratio, proliferation rates, and this fixed onset time, and so on for the DI model. So we made also a simple kind of website implementation of this, just putting these formulas in so a potential user could just enter these things like number of dose fractions or dose per fraction, total treatment time, or change these parameters if the user wants. And you get on the right here, you get these BED numbers for the two models, which usually will not be completely the same. But then when we apply this to the actual data, in an initial very simple comparison, if you just do a Cox regression, putting in these BEDs, which are the top rows here, along with some other relevant features like age, sex, smoking, stage, HPV, and so on, you can see in this case the DD BED version was significantly associated with mortality, was protective. The DI didn't quite make it. But of course, this is a very simple type of model with many assumptions like proportional hazards, which in this case is not really satisfied. So looking in the more complicated random survival forest model, which is not linear and doesn't have as many assumptions, you get kind of similar trends that on the bottom here is be the DI model on the left or DD model on the right, and on the y-axis is the SHAP values from the forest. And you can see also these kind of trends that high BED, as you would expect, is lowering mortality. And the curves are just polynomial fits. And then to put it in more context, here are the SHAP values for the other features in the model, not just the BEDs. So on the left, the scale is mean absolute SHAP value. That's the bars. And the features are on the left written there, and they're sorted in decreasing order. So as you probably intuitively expect, the BEDs are influential. They have some effect, but of course, other things like age or HPV or stage, of course, have a much bigger overall effect. And on the right, it's a diagram showing more or less the same information, but more detailed, where each dot is an actual patient SHAP value, and the scale on the x-axis is the SHAP value magnitude. So negative means reducing mortality and positive means increasing. And the coloring of the dots is the feature value. So blue is low and red is high. So you can see, for example, with the age on the top, that high values of age, so red dots are on the right, means older age associated with increased mortality, of course, and younger age, the opposite. But of course, those type of predictive analyses treat all the features the same. They do not isolate the treatment effect, like something like radiotherapy or chemotherapy. And for this reason, we looked at the causal machine learning approach as well. And generally, this might not be very intuitive to many people so far because ML is usually used for prediction tasks in a variety of different contexts. But there is definitely a field of causal ML that various researchers are trying to adapt the ML methods for causality because it's scientifically important. It's kind of a different type of question. And potential key advantages are something like this, that for personalized medicine, it's definitely useful to study heterogeneous treatment effects. For example, how the treatment effects vary by the disease details, by maybe mutations, or patient demographics to identify which patients or subgroups benefit most or least from the particular treatment. And in some cases, even the signs can be different. Like, say, overall, most patients benefit, but maybe a subgroup do not. And unlike correlations, causal effects theoretically can better translate to other data sets where the data distribution and correlation structure can be different. Definitely the observational clinical data, or so-called real-world data, which are not randomized, are much, much more available than the randomized clinical trials, because trials, of course, are expensive, they're difficult to do, in some cases impossible for various reasons. But these type of causal ML can potentially help to extract more causal insights from these real-world data. So, of course, this is not as high standard as the RCTs, but more reliable than using a predictive model on those data and interpreting it in a causal way, which can be unreliable for sure. And also the causal machine learning techniques can be used to analyze the clinical trials data as well, even though, say, the average treatment effect is already known from classical analysis. But this type of ML analysis can help identify subgroups, kind of as post hoc exploration, to identify where the treatment may differ strongly from the average. And this slide here shows this kind of framework for the causal inference. So it can be visually represented by DAGs, directed acyclic graphs, and a very simple example is on the right here, that in a predictive task, it's basically just two types of variables. There are predictors or features called X here, and an outcome called Y. But in this causal inference framework, you're also isolating a treatment variable, or maybe more than one, which is treated differently. That's called T here in the red box. So the idea is to estimate as best we can this red arrow, that causal effect of the treatment on the outcome, but of course considering the other effects of X. Which they can have. Of course, in reality, these DAGs can be quite complicated, and they come from domain knowledge. So this is not, of course, not a causal discovery problem, which is way harder. This is an inference problem where we assume we know what this structure is, but we don't know the strengths of the effects. And there are several definitely assumptions in this, but the main ones are that there is no unmeasured confounding. Basically, all the relevant confounders are in the data, which in reality, of course, is hard to satisfy, probably never completely satisfied. But there are indirect ways to check this with sensitivity analysis, refutation tests, things like this. And another assumption is usually called overlap or common support, meaning that every individual has a positive probability of receiving each treatment level, meaning that there is some stochasticity, like given X, there is some stochasticity in the choice of what the treatment will be. It's not 100% that this person, or 0% that this person will be treated in a particular way. And this can be tested in the data directly. So this field is pretty big, and there are many techniques in it. It's evolving very quickly as machine learning in general. So here are just some examples. So this DML approach, double debiased machine learning, comes originally from researchers in economics. So the primary author is Dr. Chernozhukov at MIT and his team. And as you can see here, what's nice about it, it's not a particular algorithm, it's actually more like a recipe of approaching it. And different algorithms can be used for the different steps as appropriate for the data. So instead of using one ML model, you're actually building three, kind of separate model for the treatment as function of X for the outcome as function of x, and then do a residualization step and relate the residuals to each other. So that is the approach to isolate the causal effect from the others. And it's targeting the average treatment effect in a kind of global regression approach. So the properties on the right, that theoretically it's supposed to have this very nice double robustness property. So the effect is reliable even if one of the submodels is not completely specified. So only one needs to be correctly specified. Of course, in reality, probably neither one is completely correctly specified, but it works pretty well in simulation. That is easy to check. Like if you have the known treatment effect, you can, of course, validate it. And in practice, these nuisance function models need to be reasonably accurate, like not to overfit very much. And you could check that using basically regular techniques as you would do for predictive models. And then a related technique, but somewhat different, is the causal forest. So the primary group of authors here comes from Stanford, also economics, econometrics originally. But definitely these techniques are applicable to medicine and are being used more in medicine. So here the main idea is still this residualization step, but instead of a kind of global regression context, here it's using a random forest type of idea to split the data into little parts, like leaves or voxels, as you might imagine. And within each one, you're estimating the local treatment effect by this residual versus residual regression. That is the main idea. And there is a variant of that for survival data, because survival data, of course, is tricky because of censoring. And in the medical data, definitely many patients are censored. So the version of that is called causal survival forest. So what we used here, it's implementation in R in this GRF package, which I pasted here. And the causal estimates or metrics here are survival probability or restricted mean survival time. So those are the outputs of the model. So basically this SP is a vertical difference kind of between survival functions at a specific time. And RMST is kind of the integral of that from time 0 up to the given time. And an example of what we got is shown here. So if we use the BED from this DD model variant as the treatment, and we split it into low and high groups, we can look at what the causal effect estimates are for RMST or SP as function of time after treatment. So time is on the x-axis here, and RMST is on the y in panel A, and survival probability in panel B. And these box plots, they show these estimates over different cross-validation folds. So there were 10-fold cross-validations. So you can just see how they vary over these repeats. So in general, you could see that for the RMST, there is an advantage of about 1.5 or about half to 1 year, or for survival probability, about 5 to 15% for somebody having high BED versus low BED several years after treatment. And of course, the model considers the other features. And then for the different causes, we didn't look just at all-cause mortality because the data set fortunately had different categories of deaths. So we looked at 3 different types, which is index cancer, so recurrence of head and neck cancer, or other cancers or other non-cancer diseases. And here we use the predictive model, also random survival forest variant for competing risks. And the output looks something like this on the right, where time is on the x-axis, on the y is cumulative incidence, and the black curve is for index cancer, red is for other cancers, green is for non-cancers. So these are averages over the population, but you can see different patterns. Probably intuitively makes sense that, say, the head and neck recurrence After about 5 years, it saturates, doesn't really happen anymore, but other causes keep building up over time. Okay. So then we looked also at chemotherapy effects. So I wouldn't go through all of the details because we're a little bit short of time. So we used chemotherapy as the treatment. We calculated propensity scores for it as it's described here, and we looked at causal effects of that. And this plot shows that definitely the probability of receiving chemotherapy is not the same across all patients. Depending on age and stage, it varies. So that was the rationale for the propensity score analysis. And the outputs are from the causal forest that chemotherapy versus not having it, there's definitely a big advantage in survival, several months of RMST or 15% absolute survival difference. And the histograms show distributions across individual patients, showing that actually for some patients, the effect is much bigger or much smaller than the average. And then future directions, we want to incorporate image data. There are image data available for this data set, CT images, and some radiomics already extracted by the Princess Margaret group. And we have people at Columbia and there who would want to be involved and want to carry this further. So in conclusion, this is an example of combining those concepts from simple models with an ML context, with predictive or causal ML. And we found some effects. They're more or less in line with the current knowledge, but the chemotherapy effect actually was bigger than previously published RCTs suggest. There might be some reasons for this in this population. But of course, this is just an example. And in general, we think that this concept is pretty simple and probably quite promising to apply in different medical contexts. So thank you very much for your interest. I appreciate it. And in case further discussion, I put my email.
So we have the last speaker from the session, Gilbert Liu from Radiation and Factor Research Foundation, Japan. And he will talk about the promise and the challenge of deep learning in radiation risk assessment.
Hello, everyone. My name is Gilbert Liu. I'm a senior scientist at RIRF. Today, thank you all for coming. It's an honor to be here. Today, I see everyone talk about a large data set. So you have a multimodal data here. We are doing the same thing. We're doing the image, chest array image for the user AI for biological age prediction. This is the set result. So we want to look at AI to understand the radiation risk through deep learning to see the challenge and the missing. So we know that exposure to ionizing radiation from natural and man-made sources are unavoidable. So accurate radiation risk estimation is essential for radiation protection. However, while the higher dose radiation risk are well known, the health risk of low dose less than 100 milligrams remain uncertain and debated. So there's some epidemiology study evidence for the low dose, but it's controversial. So the model people usually use is a parametric model. I call it nonlinear parametric model, but it's a parametric model with Poisson laws for the person-year table data. They include the two parts. One is we predict the tumor risk, include the basic risk multiply the radiation risk. So you see the mu0 is the baseline rate, is the function of other factors like gender age, city, and not in the city. So the radiation dose, because they're based on the gamma and the neutron, is the linear or linear quadratic. So is a function. Then they have an age modification term. So that's age-related effect modification term. The model has been used for radiation risk estimation for over the last 40 to 50 years. It's very popular, and that my former colleague developed this. It's very simple and easy to interpret. However, there are some challenges with the parametric model because the parametric model have been critiqued for inadequately addressing uncertainty in the low dose range. Also, the age-related modification in radiation risk are typically fixed by a specific function form. So we try to explore if the deep learning has given some new insight. We apply. So we know the deep learning have some advantages, greater accuracy and flexibility. Also, there are some limitations if you apply the complex model to a simple data because it's very difficult to interpret. So we will address the limitation with the deep learning. So the future direction, maybe we want to integrate the deep learning with into the risk model, parametric risk model. The third one, we try to explore how AI can enhance low dose risk estimation. So even we cannot directly use it. It provides some new insight, so can help us develop a new parametric model. Deep learning, as I said, I use a very small lidar. So they have 3 deep learning methods. One is the feed-forward network for tabular data, recurrence neural network for time series, and a convolutional neural network for the spatial time like image data. So right now you have ChatGPT, we have transformer. They can do both for the test and the image data. So that's our original data set we have with public data. It's not personal. So the solid tumor incident data, we have like roughly 25,000 per cell cover like 2,700,000 per of follow-up. So the solid tumor, we have the case is 17,000 tumor case among the 100,000, 5,000 survivors. So the radiation risk estimation is based on the per-centimeter weight, adjusted and truncated colon dose. Leukemia, similarly, we have much less case because we have 491 leukemia cases among the 113,000 survivors, roughly. So the per-centimeter is stratified by the age at exposure, attended age, time sense exposure, gender, city, and not in the city. So of course, for the leukemia, we're based on the marrow dose. That's developed by the RIRF. So we use a simple structure, DNA model, because this is a very small data set. So the model architecture is only 3 layers, 1 input layer, 1 output layer, and 3 hidden layers. So with like 64, 32, 16 nodes, we just choose this for comparison. The model selection is based on the 5-fold cross-validation. Loss function is called negative Boson log likelihood. Certainly, deep learning model have several advantages. One is it is data-driven and model-free. So the DN model-free, we mean they can approximate the underlying function without encoding any specific functional form. It's also nonlinear. It's learning from the data. The model infer the dose-response relationship directly from data without imposing the predefined function form. So how to use this model to estimate ER? So first, we estimate the impact incidence with the μi. Then the baseline risk is by computing the baseline risk by setting the radiation dose to 0. So estimate the baseline absolute risk by their ratio. So either by the baseline risk is mu I0 divided the absolute risk is divided the percentage. We calculate the relative risk is the ratio. So we have the risk with dose, the tumor risk with dose. The ratio -1 is the excess relative risk. The model performance certainly the average negative log likelihood on test data. The additional metrics like root the mean square error, mean absolute error, and some Poisson regression related loss function. So we compare with two standard parametric model they use in the early publication, very similar at least. So you see the baseline in black, they are actually adjust for the gender and for age, male age, female age, they have some function. So the red one is the direct dose response. It's the linear dose response for solid tumor. You have the age modification with the term in blue. So both have the same structure, but a little bit different variable for different tumor. That's the early publication. For the leukemia, it's the quadratic, the linear quadratic dose response. So we compare the performance. You see the leukemia, the DNA achieved a similar, comparable performance in predict the leukemia incidence or leukemia risk, and the better performance in predicting the solid tumor incidence. Of course, if we choose a different model by AI, different deep learning model, we can get a better result. However, you see here, even the deep learning and the parametric model yield significant different radiation risk across those range, despite their similar performance in the predicted mean incidence. So even the total risk, the tumor risk, they are similar, but the radiation risk actually is different. The functional form of the parametric model can significantly impact the radiation risk estimation. So that indicates good tumor incidence prediction doesn't guarantee accurate the radiation risk estimation. So the ground truth actually is unknown. You can see the model here, the dose part, the dose response part actually is very, very similar across different models, only the age modification. You see the parametric model, they have certainly they predict a larger value with a large interval. In the low dose, similar. So you see, the red one is the parametric model, the blue one is the deep learning model. So you can see they are different. With the low dose, we can see much clearer. The parametric model they have with larger value, with large variance. So want to explain, we use the Shapley value table. The Shapley value derived from game theory. They quantify the contribution of each variable to model the prediction. So the Shapley value actually decomposes the model prediction into additive contribution from different variables of a clear measure of feature importance or variable importance. So the Shapley value for solid tumor rate and the radiation risk. So the top four factors influence the tumor incidence or the tumor risk in both deep learning and the parametric model are age, attended age as exposure, radiation dose, and gender. So they are very similar. However, despite their similarity in feature importance for the tumor risk between the deep learning and the parametric model, the feature importance for the ER, the radiation risk, differ significantly between the two models. So you see the top one with deep learning is the radiation dose. Other factors affect much smaller. For the top one, for the parametric model, is actually the age at exposure. So the radiation dose is only the second important factor. So the age modification term again contributes to the observed discrepancy. For the leukemia, they even significance. So for leukemia, we know the top 3 factors influence tumor incidence in both deep learning and parametric model are same. Radiation dose, tender age, and gender. So they are same with the top one. With the radiation dose is the most significant factor for leukemia. However, the same thing, despite the similarity in the feature importance for tumor incidence, or the tumor risk between the deep learning and the parametric model, the feature importance for the radiation risk and differ significantly between the two models. You see, for the leukemia, radiation dose certainly the dominant factor. Other factor, after we adjust the other factor have a very smaller effect. However, because the function formula parametric model, the time-sensitive bullshit become the dominant factor for the leukemia model, the standard model. Again, the age modification term in parametric model may contribute to the observed discrepancy. So I give some more explanation. So we know the radiation risk by 2 parts. We have the mu. The radiation risk is the baseline risk, the tumor risk caused by other factor, and times the 1 plus the ERR. So even the 2 models have similar tumor risk, difference in the baseline function formula mu x, the baseline function, or the variance in the effect modification, the interaction term in the parametric model can lead into substantial difference in radiation risk estimation. There are several implied assumptions in the parametric model. The first one is the radiation affects the tumor risk only through the interaction of age and the dose. You see, it's the dose multiplied with the potential term. So the only through interaction. The second one is the radiation risk depends on the dose in a linear or linear quadratic form. Will it association with age following the exponential, the first term age at its birth, or the power term? So what is the Shapley value of the deep learning reveal? The radiation contributed to tumor risk both independently. So you see the part, the white part is independently and through interaction with the baseline variable. So after adjusting the baseline in the model on tumor risk, the contribution of baseline variable on the radiation risk will become smaller, along with the intuition. You see that, the back. So for here, so the left by deep learning, after you adjust the other factor in radiation risk becomes smaller. So that's it. However, in the parametric model, because the only baseline interaction is not necessarily becomes smaller. So there are several barriers if you apply deep learning for the radiation risk estimation. The first is, you talk to the statistician, talk to epidemiologists, they always talk about inference. We talk about the prediction, how accurate it is. So their terminology, there are gaps. You try to convince them use this method, it's a little bit difficult. It's a challenge. So another is, how can we decide the baseline risk or age modification? So we can identify the source of baseline risk. Effect modification in the parametric model is challenging. So we can we really, based on the deep learning, to detect the baseline risk and the model effect modification automatically, learning from data. That's what we do. But their domain knowledge, we modify it by guided by the radiation physics or radiation biology, linear quadratic, linear model. We have to balance the data-driven learning with the domain expertise in this both. Another is deep learning model is intricate and less interpretable. Even use sharper value, it also requires substantial computing resource, and estimate the confidence interval with deep learning is not trivial. However, we said even this deep learning can still help us build a radiation model. So we next topic talk about low dose radiation risk estimation guided by deep learning. So we know the individual tumor risk very significantly is heterogeneity. Radiation risk at low dose, less than 100 milligram, are also likely heterogeneous. So the epidemiological evidence on low dose radiation risk is crucial for radiation protection and policy making, but its carcinogenic effect remain unclear. The standard parametric model struggle to detect statistically significant radiation risk at a low dose. Our goal is want to leverage the deep learning learned individual risk heterogeneity to improve the low dose risk estimation. So we know there are several models. One is called superlinear, another linear no threshold, and homothesis. The linear no threshold model is developed by RIRF. So it's most widely adopted model by regulatory base. It's really on low dose extrapolation. So it's based on whole dose range, then they assuming they are low dose extrapolation. So the threshold model have zero, they're assuming zero or near zero radiation risk at a low dose. It believe very small radiation exposure are harmless. It made more noise in the last several years. Another is most epidemiologic data analyze data as a whole and overlook the heterogeneity. So we can see that's the lifespan study cohort, is the famous cohort we use for make many policies. So if people have tumor, they are tumor sensitive. The tumor sensitive is caused by radiation and many other factors. You see the left branch. If people do not have tumor, it's likely tumor sensitive or tumor resistant. We don't know. However, if the people are tumor resistant, never develop tumor despite exposure to all potential risk factors, including radiation, we think they also radiation resistance. The concept is not related to biology, maybe not exactly accurate. Is talk about the biology data, only epidemiology data. So the insight from sharply value deep learning in leukemia risk estimation. The sharp value from deep learning tell us radiation dose is the dominant factor for both radiation risk and both tumor risk and radiation risk. So the subject with leukemia are likely more radiation sensitive. Since we don't know, we cannot distinguish the radiation sensitive from resistance in the subject without leukemia. We fit a zero truncated Boson model from the zero dose to the given dose using only subject with leukemia. Our goal is fitting zero truncated Boson model use only the non-radiation sensitive group. So we can see we fit a zero truncated Boson model after log transformation. We can detect the statistical significant coefficient in radiation risk in ERs for leukemia sensitive subject in the 30 milligram to 8 milligram dose range. You can see the top one is the coefficient, the bottom one is the ER. So it's very simple. You can check the confidence interval in the middle one are positive. Also, the ER for leukemia at low dose are highly nonlinear because the coefficient is very large with the beta much larger than 2. Another is the insight from the sharp value of the deep learning for solid tumor. They are a little bit difference. We know the sharp value for deep learning model, the top risk factor for solid tumor are attained age and age and exposure. So radiation dose is only the third most important factor for the solid tumor incidence. So individuals with solid tumor are not necessarily radiation sensitive because they can caused by other factors. Since age and age and exposure are strongly associated with tumor rate, so they may help distinguish tumor resistance from tumor sensitive group. Our goal is try to include the tumor resistant group from the data analysis, use zero inflated Poisson regression. So this is a little bit, probably everyone knows this, but the assumption for the zero inflated Poisson model is not everyone develop tumors. Some group may have inherent resistance. So the deep model assuming two processes. One is the binary process where some individual Okay, that's the deeper model can distinguish tumor-sensitive individual from tumor-resistant one. So we fit a deeper model and the Boson model. You see, Boson model cannot detect any significant risk at low dose, but the deeper model can. And you see the beta is 1.45 with between 1 and 2. So the dose response relationship is linear quadratic. So our conclusion is the deep learning model may offer new insight into radiation risk assessment. The sharper value can help identify radiation sensitive and radiation resistant groups. Also, the dose response relationship at low dose may vary across the tumor type and individuals. Another is identify the radiation sensitive group using epidemiology data alone is challenging. As the tumor sensitivity does not always imply the radiation sensitivity. So if the low dose threshold exists, it may vary by tumor type and individuals. So we need a multimodal analysis so that we integrate epidemiology data with the biological data. Right now we are trying to do that with the image data to improve the identification of radiation sensitive and resistance groups. So the personalized radiation risk assessment hold promise for future advancement. Finally, the acknowledgement we have collaborators doing this work. Dr. Igor is here, and this is supported by National Academy of Science and the DOE and the Japanese government. Thank you. Yeah.
Thanks very much for all our speakers. We managed to get everyone on time. Just like before, we probably need to start the ball rolling by asking a couple of questions, and then we'll get to the Slido for audience queries.
So we have I just want the Slido, and there's a session A and session B, and this is session B. If you have questions, type in session B. Do you want to start? Okay. I can start my question. There's a question for Nor. So very nice talk, and I actually learned quite a lot about human AI interface. It's very useful. I'll just move that a little bit closer. So I think you mentioned that you need an interview with the physician, clinicians, all the potential users. From my experience, if you interview one person, which is okay, but if you interview a group of person, you get different variety of the answers, right? That's one of the challenge. Second, so the group of the people you interview have different technology background, especially when you talk about AI. Some people tend to say, okay, I don't believe that. Yeah, even interview me, I may not give you something useful. And some people are very tech savvy, think, oh, this is wonderful. I want to use AI to do A, B, C, D, E. How do you handle this case, right? How do you get you a final conclusion which make everybody or almost everybody satisfied?
Those are great questions. Thank you. So definitely there are challenges in doing this kind of work, but I guess the short answer I have for this is basically you're not trying to prove that, oh, like this solution or this particular interface will work, right? You're just trying to get the initial reactions of people to understand the clinical utility and their sort of overall acceptance around the potential use case or an application. So there were definitely sort of different preferences around like how a draft report should be presented, how they want to interact with it. And typically like the limitation is you have a smaller sample size. So I think we had maybe like 13 people. So the idea is, again, we're not trying to sort of validate the actual design and say, okay, this is good, we're going to build it as is. You just want to have the people come in and take a look as early as possible. And you want to keep doing this throughout just to sort of have a sort of sanity check. And I think once you have that, once you have an idea of like, oh, this direction seems promising, then as you build more and more, you talk to like more people, maybe you do more like rigorous studies and like actually assessing the certain metrics, like how much time they spend completing this task. And you want to like measure things at a more like lab setting to see like how do they use this? Is this system usable? So this was just a very preliminary study.
Oh, I think I agree. So my experience that you take one clinical champion and one of the physician, one or two, who is very interested, and you make a prototype. As what you said, you put into some kind of a simulating environment, and then it will propagate to more people, start using you, collect more feedback. It is something more practical, right?
Definitely. So this is sort of going into that direction. And the point you had about people's sort of familiarity with tech, I definitely agree that matters. So we always try to get a range of people. So some of the people we had were like really familiar with AI development. Some had like no idea, and some were in the middle. So I think you definitely don't want to sort of bias your group and want to have a variety of people with different levels of expertise.
Okay, thank you. I have a question to the last three speakers of this session. We learned yesterday various issues with data quality of the underlying images, tables, tabular data that we have in terms of their reliability and variability. So when we do multi-data, multimodal modeling involving these underlying images and tables, which has intrinsic variabilities, how reliable would be our model? I mean, in terms of robustness and generalizability, is there a concern that this is a one-off kind of result per institution, and that you cannot, you may not be able to translate it to another one just because of this variability of the underlying data? I'm a little playing here devil's advocate, you know. When you go from MD Anderson to Stanford, could you go to, let's say, Wash U or UT Southwestern or a community hospital and use the model and obtain similar results?
I'll try to answer first. There's a multiple of the projects I have showed here, and of course we have concerns for the data. I think there's a lot of things I think changing with the recent maybe foundation modeling, because people start to, when I first to get into the radiomics, people say quite a lot like garbage in, garbage out. But what define garbage, right? I think garbage means maybe something. Let's see, if I want contrast CT, you not give me what I want. Maybe that's not something. I will classify that as garbage, right? But these days, when you start to build a foundation model, if you look at all these papers or look at how people doing that, they start to really relax the data by treating the quality to the quantity. So basically, they want more. But once you get more, you lose because the things, once you put more threshold there in front of the data, you lose more. So they are treating the quality to the quantity. And I see, there's so that's a lot of things might change there under this, the foundation model. And like when you look at how the OpenAI build the ChatGPT, basically, there's a Like I watched that YouTube for 3 hours and they show me how to do that from like steps. And you are surprising to find out they just, there's someone download the data from all the internet with just a very, very, not that many threshold out there. And all of a sudden the AI, the ChatGPT are so, so powerful. So there's some patterns. It's really good at learning the patterns. So I think back to, back to reality. I think in medical imaging or in the medical field, we are still in stone age. I think that's unfortunately, because when I start to chat with all the clinicians, oncologists, all about these things, the things, always they're asking me how large the data you want. I'm thinking, maybe millions if possible, they say, okay, there's no way we can get you that. We have a database which can give you maybe 20,000 of the lung cancer patients. And even that treatment are evolving. Because, when I show there, for the past, luckily through MD Anderson, we have this moonshot project that started curating the multimodal data that is a foundation for all the project I present. But as you see, the treatment landscape are evolving. There's like the people using the public data, like the NLST data, but the scanner is very different. And even the enrollment criteria now, the US TSPF are evolving. And it's not like when you define at that stage the eligible patients, and now it's very different. And also like the treatment, like when they first started curating data, there's no immunotherapy exist, and no these new drugs exist. And so that means, when you're curating that, even that's high quality data, you show the patient outcome, progression, but it's old treatment, right? It's maybe irrelevant. And people like to use a TCGA quite a lot. And not talking about the quality of that data, but just the treatment is very different right now. We have the surgery, like the neoadjuvant or adjuvant treatment right now, like evolving so fast, even the clinicians are struggling to capture the landscape. So that's why I'm thinking, of course, we want more data, but I think the quality of the data and also depends on the stage. Let's see if I'm I think, we don't want to mix different things in one project, because to be honest, I think whatever we publish may not changing the clinical practice, but we are just maybe, in my opinion, it's just running a pre-clinical study on the imaging field to show if there's any signal we can tease out from this data. If so, that may be worth to bring that to the phase 1, phase 2, phase 3, and to talk to the different centers. And another point is like, I hear a lot of talking about federated learning yesterday, and just our experience, we talked through all these oncologists, we talked to the different centers here, Stanford, Harvard, Mayo, all these big centers, and we always want to get their data. And the problem is, we currently have this breakthrough foundation where we have 9 like cancer centers sharing the data. We are going to have the radiomics data. But the first couple of the meeting we have there is they're asking me how I can give you the radiomics data you want. They're all the oncologists are willing to give me the data. I say, how can we do the federated learning? That's sorry, I don't have the IT support. I don't have the people who can even coding in my lab. So that's a reality, and then we say, okay, then just download the data, de-identify the data, throw them into the whatever cloud your institution allowed, and then we just grab the data to our center, and we all have the centralized annotation and analyze on that. So that's I would say so that's why I classify that as a kind of the stone age. Yeah, I'll stop here. Yeah.
Yes, I guess I can add a little bit to that. So for the tabular data that we were working with, for example, for that head and neck example and some other cancers, the data set size was not that enormous. So it's several thousand patients. So mostly that was manual curation of the data for mistakes, various visualizations, looking for outliers, and just kind of common sense. But it's not easy to check for mistakes, as we heard many times. But also, of course, this problem of model trained on one data set, say from one institution, doesn't translate as well as hoped. Definitely, we see that before as well. For example, with head and neck cancer, say something between US and Europe, like for example, Poland, there's translation is not as good as whole because maybe there are other population differences. Maybe the risk factors are different. For example, it's more like alcohol or smoking driven, whereas in the US it's more HPV driven and so on. But theoretically, the causal approach should alleviate that somewhat, at least.
Yeah, the worry is like the linear quadratic model as the initial data set that you have was made during 1980s, as you mentioned. And treatment techniques and doses have completely changed since then. And so how generalizable would this model be under the current clinical practice, so to say?
Yeah, well, that's another important question for sure. I know there was a debate with things like SBRT, for example, when the doses get really big, more than say 8 gray per fraction, then there was a bigger debate whether the linear quadratic still holds or it has to be linearized again. In the head and neck specifically, I don't think it's that relevant because that kind of fractionation is not used very much yet. Like most of that data was close to standard fractionation, or the newer trials are using somewhat accelerated, but still not that far from 2 gray per fraction, maybe up to 3 or 4.
And for the last speaker, I was wondering whether how your mother would, let's say, generalize to the recent examples of Chernobyl in terms of solid tumors or a leukemia model that you have, or the ERRs.
Right now, for that one, I never access the Nobel case. So that case, the Russia case, I never access. You could buy that data, I never access that data. I don't know. Yeah. For the quality, I have something. I think the AI model is not totally intelligence. If the AI model never see the data, then you have very different quality. They never see the data. Your example is very different from the data training by the model. Then the model certainly perform bad. The only ability the AI model is that it can handle heterogeneous data, but the model have to see in the data to predict well. So I think the quality is important. We're doing some project in chest X-ray. We check the quality. We try to make sure our A-bomb survivor, the quality is similar to the quality who trained, used to train the model. So in that way, we guarantee that can, because we deal with the Japanese population. They are different ethic, so we don't know if they perform well. If they don't perform well, we need to use transfer learning to retraining the model. So that's the only thing. I think the quality is very important. Yeah, that's what I can say.
We get some question from Slido. I think this is a full panel for everyone. As we start to adopt multimodality models, and so what's the best practice or strategy we can ask the researchers to label this data for the best practice and using these applications? I mean, those researchers is come from different departments. Right, so you could have get data from pathology, data from radiology, radiation oncology, when you combine them together. So what's the strategy or best practice for them to label the data for the future model build?
Maybe I can start on that. That's a tough question, but I think going back to the sort of last slide I showed, having like tools built in the first place with labeling in mind, I think really helps. So when I started at UVA, I was like really surprised when I saw that the interactive reporting systems they had, that so typically you do have those kind of tools where the radiologist can actually like label an image, but most of the time people don't do it because it's just either hard or time consuming. But I think they sort of like established that early on, and they have a sort of good amount of adaptation. So they've been creating this data set. And I think it really comes back to sort of like thinking about the whole sort of pipeline and infrastructure to actually build that sort of tooling in the first place. Most of the current sort of healthcare tools and interfaces are really sort of old, sort of enterprise systems that there isn't much sort of choice or variation. So I think sort of going back to the tooling with having the idea of like, oh, what kind of labels will we need? Like thinking about those and going back to the tooling with the end goal of like creating that high quality data set in the first place. I think that's where the future, it will be really important for this kind of multi-modeling approach.
Maybe I'll add some of the experience we have done. I'm really fortunate to sit in a very clinical rich environment, and through the oncologists, we collaborate with surgeon, with oncologist, pathologist, and all these basic science researcher. And I would say, first, you let the expert doing their job. I think when we labeling anything, let's say if we label radiologist stuff, now my postdoc or people get involved and to tell them what to do. They are the one telling us how they are going to do that. And I think that's and also we learn from the literature, we discuss with them, we offer sometimes if there's a tool there we can offer to them, great. If no, we'll do our best and see how we can get it happening. And of course, labeling the multimodal data is super challenging, I would say. There's a lot of manpower issue there. Like, give you just an example for the radiology field, we try to annotate the whole body CT scan and to get all these 3D volume segmented that's from the metastatic lung cancer patients. So we hired about 5 foreign trained experienced radiologists under the supervision of our radiologist team, because no radiologist in MD Anderson will have the time to get to do the manual work. I think maybe that's true everywhere. The radiologists are really, like overburdened for the things they are doing. And if you ask them, hey, help me to do the annotation, nobody can do that. And so, so what we have done is for this team, they form as a team to do this meticulous whole body annotation for past maybe 5 years. And till today, we get maybe 5,000 cases annotated. And that's maybe the largest well-annotated whole body, CT scan. But still, how do you make sure everybody agree on every case? And there's always measurable, non-measurable, like target lesions out there, such as maybe bone. Will you agree on that? And always there could be a debating where to draw the boundary. So that's why but I think this is a chicken egg problem. You need to have this annotation, high quality annotation. Then you can start to develop some tools, and hopefully these tools will be able to test in a meaningful way and to elevate some annotation work. So we are, just in the phase 1 to collecting this very expensive data right now. And next phase is to see what are the tools available. And the first step we do is to without, just go there to say, hey, everything else there is garbage, let's develop our own. No, we just say, hey, is there any tool we can use maybe to see, we benchmark them and see something's good, something's bad. And then let's see, can we polish this tool with some expertise we have, because we are not Google, we are not like OpenAI, we have all these unlimited resources. So that's why I'm thinking doing that multimodal is definitely a challenge with a resources limitation and with all this, access to these different clinical team. And I would say you need to build maybe some workable solutions case by case. So yeah, that's just our maybe experience in this field.
Yes, I definitely agree with previous speakers, and I think at Columbia it's going on kind of more or less the same way, that we try to communicate with the different clinicians and mostly adapt to the workflows that they do, and of course explain what are the benefits of combining, of analyzing together.
At RIRF, we are a little bit different because we based on historical data. So with the cohort image already measured. So everything, the clinical data already in there. So what we try to standardize the ITD department, try to build a database so we can link them together. We can put it in the user-friendly format. So the quality we cannot control, it's already done. But the point is, how do you make it can be used directly by the model? So it's like you have to communicate with the ITD department. So because Japan have a lot of restriction on personalized information, we have to handle that very carefully. Also, we need, in the process, you need to always talk to the ITD department. You handle that. That's our experience. Yeah.
So a provocative question on the linear no threshold question.
Okay, go ahead.
Since it looks like the experimental basis for it has been questioned and or suspect, so to say, shouldn't one just abandon it?
You know, that's, I think the linear no threshold method have its advantage. It's very simple. You know, we do have some evidence based on the high dose. We fit the whole model, then it's dropped there. We do have some really evidence there. That's why people use it for the last 40 years. However, they do have some limitations. We don't provide actual low dose if it's significant or not. I believe, you know, if we don't try to abandon it, maybe we try to think a different way, different tumor. You know, for solid tumor, maybe you have a threshold, right? You know, it's less radiation sensitive. For leukemia, I don't think so. I think, you know, there is, it's not for all tumor. Maybe for some tumor, they have a threshold, but the threshold have to be different for different tumor. Yeah, if there is a threshold, I don't know. This question is a challenge, right? I think the linear no threshold still have it merit. Yeah.
So in the Slido, I think that this question is for Jia. And so the audience asked, so I remember that you show one of the slides, so you synthetic PET, the PET scan from the CT. So this question comes with, you know, CT is to measure the electronic density, but PET is measure the metabolism from the cancer cell, right? Consume yearly, it's the FDG. So how do you see that Y model can predict the functional information from the anatomic informations in CT? Is it reliable? Because they're from different mechanics, and yes, they will show as the same as the image modality, but underlying is different.
Yeah, I think I totally agree. You know, when we have this project actually is one of these most challenging projects we spend to get it published. That's you know, we have keep on adding and adding more to persuade the reviewers, and until they are really satisfied with what we show. So, but I want to maybe clarify a few things. I think, you know, doing from the CT to PET prediction compared with yesterday, what you know, they show the synthetic data, that's very different. Because if you think about that synthetic data, is you have patients points here, you try to kind of leverage the neighbor of these patients, then interpolate together kind of non-exist points. And here, what we try to do is every patient can get a PET scan. You throw this patient into a PET scanner, you will get it. The things you don't have it in certain cases. And you will find out in a lot of cases, you don't have it. And, you know, when we do that study, we find out in, you know, not just to mention here in the low and mid income countries, there's just 5 PET scanners out there for like hundreds of the millions of the population out there. So that's a reality, you know, there's a gap there. And here we try to do actually is no different than other things, just feeding a function from what you see from anatomic signal, try to predict their, for the FDG pad is metabolic activity, right? And here, I think, of course, is there really a magic there? Nobody knows, and what we have done is just, the data is data. When we show the code is there, anyone can take the code from our GitHub and try it. And we test it, and we find out that's surprisingly really something good. You can light up this tumor. And I think if we, like defend this idea back, or the radiogenomic idea, when I first stepped into doing this radiomic study, people look at the radiomic scan, they can predict the gene mutation, they can predict the histology, they can predict anything they want, right, from the scan. How does that really there? It's not intended to measure that, right, on the CT scan. So that's why I'm thinking there's maybe some hidden patterns out there. Like yesterday, what we observed, there's a like an eye image you observe, then you can link to all these things. So I would say, is that true signal or not true signal? We don't know. I think, what we observe is just 100, 200 PET CT scan pairs we observe. So what we are doing right now is we're collecting all MD Anderson PET CT scan. That is roughly to a range of 500,000. So in the first batch we get is almost like, 50,000 PET CT scan from different patients. And what we are going to do is let's scale this up, throwing all this data here. And this can be, let's first say, before we know why it can predict. First, let's see, once we have this model here, we can embedding this model in clinical practice. This patient have a CT scan, and we can predict the PET scan. And this patient may, have a PET CT ordered. But before they even order that PET, get that PET CT, we can generate that and see does that predicted one really in line with this, with this ordered or machine generated PET CT. Is there truly some correlation there? So this, I think, will be a first study. We need to scale this up and test it. And on the other side, I'm thinking this idea may even, if we take it back, it's just mathematically try to fit a function from anatomic to function, right? So hopefully there's some anatomic function from the tumor, not just tumor. We do the chest region. That means not just the tumor region. We look at the cardiac, we look at the bone, we look at the tissue. Some texture features, some of the intensity features there just can map into these PET scales. And this is just a fitting function. And the thing will be, what if there's an outlier? What if there's a patient you light up and the real PET doesn't light up? Does that mean you are wrong? Maybe not. I think maybe that means this patient is just an outlier by whatever function you fitted on the population level, right? You fit the population level, and then this light up, this doesn't light up. So first, maybe we need to check that protocol is different. If everything's same, machine, whatever is same, does that mean the biology could be different? Is that indicating there's some biology difference behind this? So if we have these patients, maybe tissue data, whatever data, can we do the deep biology there? Well, that indicating even there's a subtypes, different phenotype if you apply this. So that's all the things we are thinking. But of course, we need to first move this mountain to get all this data. Then we need to worry is, do you have enough GPU you can run all these things on? Do you have enough, power to really bring that to embedding into clinical packs? And hopefully you can start everything, just throw in a CT there, we can give you a synthetic pack.
Yeah, thank you. A question for Dr. Liu. As you update the dosimetry and organ dose calculations for your cohort, how well can your model handle these changes?
That should be not hard because we can right now those new dose development. I think this year or next year, maybe later this year, we have the new dose estimation. So we try to use it to update it. We think because that DN model is very flexible, you have a different variable you put there should be handled very well. What's the effect? I don't know yet, but I think we will know if the new dose system is totally different from what we used before. Yeah, right now we don't have the information yet. I think the NCI and our group are doing it.
So let me have another question on the linear no threshold. So you proposed a causal model in terms of Bayesian approach, right? But you mentioned in your talk that one does not really have data for the linear no threshold.
No evidence.
So how do you then do the priors?
I'm not doing the bus. I use the deep learning as a tool to build a parametric model. I'm not trying to do the Bayesian method, use the Preda. Yeah. If I use the Preda, probably I use the non-informative Preda. Yeah, there's no information there.
So in the room, the middle of the microphone is working. Does anybody in the audience want to ask question directly?
Yeah, you don't need to go to slide
Slido.
since we are
Small room. So
small room.
go ahead and ask.
Don't be shy or we will call you by name. We know you. We can.
I can go. Maybe I should stand over there and ask a question. So I think this is from I found this question from Slido in session 1. I don't know whether it's given to session 1 only or just generally also be session B, so not session A and session B. So I think it's a very good question. So what was the question is that sometimes the physician treatment is not just from the outcomes. So there's a lot of trade-offs. And I think one of the consideration the audience was asking is insurance coverage. That's some kind of financial burdens. I know it's quite of a challenge and a lot of discussion. So in terms of that, we all build the models. So you give the suggestion to the physician. And finally, they may say, okay, I think because the financial implication, and maybe there's no big difference, but insurance is covered this one, but not that one. So they go to totally different treatment. So what do you think? So I know we are not the policymaker. We're not doing the patient financial service, but that's part of this. You can see that's another modality as part of their consideration. Any comments, thoughts?
Maybe I can get started. I think we just recently published a paper to work with a surgeon, and they ask exactly the same question. They say the patients come to MD Anderson, which is charged maybe higher than a community hospital, and then the patient maybe come here, and then after they do the surgery, they find out they have the financial toxicity. So are you able to do some machine learning modeling? At least when the patients walk in the door, we can collect all this baseline, whatever information available to us. And then at least we can give them informed decision. Are you really want to do the surgery here, or you want to do that at a community hospital, which hopefully much cheaper, or should you consider other options? So yeah, we did some modeling there, and we show some, there's some factors there associated with their toxicity risk based on about a couple hundred of the patients they operating on, and they collect all this data. I would say that's a great question, because when we carry on this project, I'm having the real conversation with their surgeon and try to understand. I think I think ideal world, you want unlimited resource, you want things, but if we think about in lung cancer field, we find out the lung cancer screening is awesome, but uptake kind of rate is really low. So that means the patients who are eligible to screening, they just don't go. They just don't walk into the door. Even they have insurance, even whatever, they just don't go. And uptake rate is the number maybe, increase a little bit, but still under maybe 20%. Compared with the breast cancer screening, that's extremely low. Maybe why that happens? And, even we are keep on building the model, we keep on analyzing that, keep on changing the rules, policy, and keep on brainstorming, hey, how can we make it better? But the thing is, there's a large amount of population, just no matter what you do, they just don't go, not maybe trust it. They just maybe, some patients say, no test, no cancer, right? So that's no test, nothing there. So and also another evolving part is, like, should we really make a policy to do that, or when we make the policy? Because also for the lung cancer field is people starting to thinking, hey, should you only scanning for the heavy smoker, or you should also scanning for the non-smoker? Because there's evidence already throwing out there from a talent study, which is showing just by applying some very simple rules out there, you can identify this population, the Asian woman, have a even higher risk than these heavy smokers. And where they don't smoke, they just maybe cook. They might have some exposed to some environment. So does that mean, given all these scenarios, sometimes I throw this crazy idea to our epidemiologist or to our oncologist or radiologist, say, hey, maybe whoever want to do it, we should just let them do it. And so that way we just open that wider. And another thing will be the lung cancer screening CT scan is not that expensive compared with like PET CT scan, which is we charge maybe 10,000 for that. And low CT scan, couple $100. So that's I would say, financially, it's just didn't make sense, right? To not let these people doing that until they might have some indication. And these days want to have this data. And another crazy idea will be, can we sell this data to get the patients refunded? That is there a mechanism out there? Is there a company willing to buy the patient's data or even cover their data? I'm sure, there might be some, willing to do that. So yeah, I think it's just my observation in this field. I think it's a really complex things mixed with different treatment givers, AI researchers, patients, and I would say it's just not that easy maybe to really address this financial toxicity from the reality world.
Adding to you, in addition to what you're talking about, maybe I'm thinking, should the model predict the financial toxicity, right? It's like, before your treatment, you give the cost, or you can predict the cost, the different selection of different, the procedure of therapeutic treatment. And then either this is all patient facing or clinician facing. So they will have a goal they want to reach. So I don't know. I don't see, at least I don't read any models can predict the cost.
Great.
Yes, to add.
We have one question here from.
My name is Don Fresh, and I'm a radiologist, so I really appreciate learning from you all, and the session has been great. And I guess I want to ask something from a cost standpoint and get your opinion, but it's a different cost. It's the risk of AI or machine learning causing a bad outcome in a patient. And I'm just interested in personal opinions here. How do we as a community assign responsibility for that? In the United States, it's a huge medical legal issue, and a lot of practice is defensive medicine, and there are individuals just waiting for something bad to happen. So if machine learning, and it's applied, and it's going to be increasingly applied, if it turns out that there's a bad outcome that is attributed directly to something used, is it the researcher? Is it the vendor? Is it the enterprise? Is it the physician who's responsible for that?
Yeah, I think from research to clinical application, that's a long way to go. So if my understanding early years, I work with the US Army, we're doing some research. Some clinicians are really against it. They think you will replace them. So you have to convince them, I think it's everyone's responsibility. You have to convince the medical doctor this is useful. So otherwise, the research never go to clinic. That's in US. That's early years I doing some research. I found that it's very difficult from research. You have a model, you want people to use it. You have to convince them. You have to show they really have effect. Of course, if you have an anniversary event, certainly that's everyone's responsibility. The doctor have to willing to do it, willing to take the responsibility. Otherwise, I think it's a long way to go. Any model, no matter how fancy you are, if you want people to use it, it's a very far distance. Yeah, you have to through a medical doctor. That's what I think.
I will share my 2 cents. I think we discussed this quite a lot. I think that depends on your intended user case and also what's the current status quo there. For example, if you're saying the radiologist make a diagnosis, you want to have a, let's see, you have a fancy model, you want to automatically generate the reports, right? I would say that bar will be really high because you already have a clinical decision point guided by a super, intelligent experts and well-trained experts can do that job, very, very high accuracy there. And you want to inject your AI there. I would say the bar you need to really show your sensitivity, specificity, your accuracy to a really high value to make that happen. And even, we talk quite a lot about the uncertainty. The problem is, there's no magic about these AI tools. When it tells you it can make prediction wrong, so that means it can estimate this uncertainty also wrong. So I think that's how do you really flag that? So I think there's maybe still like you like the people doing the autonomous driving car, you may still want to put your hands there, want the radiologist or whoever use that tool still pay attention to that. But still, I would say that's challenge to do because if you see like 1,000 cases, all looks good, then you get lazy, right? You just forget about that. Then there's something slip out, then that could cause something. And I would say regarding who is responsible for that, if that truly happened, I would say, I recently go to the gym and they always ask me to sign a waiver. And there's a lot of things, pages there, and a lot of things you sign there. I would say, that's that's something we can inform, maybe do a better way to inform the patients or inform the clinician there's a risk when you use these tools. It's not saying there's no risk. Even radiologists, to be honest, they make a mistake, right? They can misdiagnose things, they might miss some things. So are they getting lawsuit? Probably yes. And who is handling that? Maybe the AI will be treated a similar way to as some like protection there. And also on the other side, I'm thinking, if you are talking about the field where there's no tools existing. So when we discuss that with oncologists as a machine learning, people are always saying, I want to see that sensitivity, specificity to be at that super high level to be confident to really move that clinical practice. But, they're always, sometimes they have different opinions. They tell me a story. Have you heard 2 medical students go to camping story? I say, yeah, no. They say, oh, okay, great. 2 students go there. There's a bear there. And one student tied the shoes and the other say, hey, how can you outrun a bear? I can outrun you, then that's fine. So that means, okay, so that means in clinical practice, if there's nothing there and clinicians all have their freedom to judge. For example, you have multiple of the drugs out there and clinicians these days, they just based on their conversation with the patients, their knowledge, and their maybe inside maybe try and error things. And in this scenario, your bar will be pretty low. If you have something, you could enter there because in reality, it's either A, B, C, right? You give that, there's no right or wrong answer here. But if you have something going there, start to collect the data, start to show something, if it work or not work in the way you like, that could be something like, run a kind of pseudo clinical trial stuff. So that bar, you don't really need to reach super high to be confident to apply these tools. And so that's why I'm thinking it's really varies case by case. And if there's there's a lot of like if the AI tools summarize what physician and a patient's conversation on the back end and help you generate the reports, that maybe it's a low risk tools to use. And even we also need to ask what will the worst thing happen if this really truly make a mistake. And we do some simulation there. And we do like the lung cancer screening, we test some of the tools out there, say, hey, what if these tools really misclassify these patients from the tumor to non-tumor, from tumor to from opposite? What will be the downstream like cost out there? And of course it's not perfect, but and then we find out it's not as bad as we initially thought. And there's some rescue there we can put out there. And we could maybe, with the technology, we could guide the patients and we could maybe find the solutions out there. And of course, the worst things can still happen. But I think that's something hopefully we are able to have the courage to take the risk and to test it.
The one thing I take from that as medical community need to begin to address a cultural change with expectations of patients in delivering a tool that can potentially improve healthcare, but has certain risks to it. And like you say, there's an understanding coming through the medical portal that you're accepting certain risks, but that we have to educate the public about the growing advances in medicine and what the implications are. I took that from that's a great point.
Yeah, I think that's good. I know the first speaker, no, and she also mentioned it's AI. It's doing better than nothing. So there's some things, and if we can use it, there's improve the outcome. We should. Well, similar, along what you're talking, so everything is a risk. Look at the Tesla, or the auto driving, and I guess I don't know. I use that all the time. Sure. Yeah, I agree. I think that's the media, because all the media is the job. It's to find out this all layers. Similar the way we were dealing with AI. I know that we are so picky about AI. I want 99, 99, 99. But as a human, we made a mistake all the time. Why do we treat AI 99, but we don't treat equally as human 99? So that's different question.
Jump in. I think this is a really great question, and I have so many thoughts about this. But I think my feeling about this is really there should always be a human in the loop to make decisions and take the responsibility. And the way I think about the value AI sort of brings into healthcare, it's really, I've never met a clinician that said, oh, like, I find it hard to make clinical decisions for this patient. I think radiologists, clinicians, they're expert decision making. Like, they just see a case, they most of the time know what to do. If they don't, they have colleagues that they can talk to. When we were sort of looking at the AI generated draft reports, and we were asking like, oh, like, would you trust this? Clinicians and radiologists, most of the time they said, oh, like, I don't even trust, like the human is not even the gold standard sometimes. Like, we get all these teleradiology reports overseas, and sometimes like they get the findings right, but the impression section is not correct because like they don't know this patient. So often clinicians would go to the radiologist in their hospital to say, look, I have this report, I don't trust it. Can you take a look at this patient? So most of the time, I think the real value AI brings is just like having some time savings on like maybe just drafting the initial findings, but like I'm not trying to tell you what to do, like what decisions you should take, but I'm trying to sort of help you maybe manage your workload, maybe sort of reduce your cognitive load, maybe manage your attention, like which patients I need to prioritize, and things like that that are a little bit outside of patient care, but really, really helpful to sort of streamline the sort of pain points all across the healthcare. So I think that's the sort of real value AI can bring. But curious to hear your thoughts.
To bring this to the realm of clinical care. And I think the comments here were from a human standpoint. We all want to know that a human is taking care of us. I think that is important, and that's a necessary part to keep in there. And we just need to recognize that that will be a necessary part of healthcare. And you're right. There are nuances in the reports that I make depending on the clinician I'm talking to, depending on the disease process and the general environment of whether it's oncology or rheumatology or trauma, depending on the individual patient, if I happen to know that, how I word specific things. And it's there's no formula to it, but the AI can improve and maybe make things more clearer. But those nuances, I think we have to recognize are important, both from the standpoint that the patient reads this often before the clinician does, to be sure you're communicating with them in a mindful way and connecting with them, as well as to be to provide something that the provider, the clinician, can act on without having to say, I don't know what's going on here. So your point is very good.
I think I just want to add another point here. I think, the AI, there's tools like you can save the time, and also there's AI can maybe better at outperform the human performance in certain tasks. So, there's always a debating there. We know, like a clinician, when they treat the patients, if you know there's a good drug, it is unethical. If you know these drugs are good, you don't give it to the patients, right? But will that be unethical if we know the AI are good at doing certain things? But we just hold it off. Don't let it to help our radiologists, pathologists to help them to do the things. Will that be, like really unethical to do that? Because as we enter the field of the true medicine, you will find out, radiology is not really quantitative. We have the RECIST measurement there, but nobody using that except maybe in clinical trials. And there's a segmentation tools here and there. It's not perfect, but can it measure that and generate something and save the time and maybe enter the clinical practice? And which is, in my opinion, have very minimum risk, because when you annotate that. Radiologists can always correct. And the worst case is you just don't use it. You just follow whatever you do the patients. So that's just I think a provocative point here is we know the AI tools are able to do things imperfectly at this moment, but is that, with the more and more involvement, will it become more, maybe the point is not saying, hey, should we use it? Maybe we should say, hey, will it be unethical if we know that tools are so powerful, it can help our patients, but we start holding it off. Just don't give it to the patients.
I think that we can thank you for the panels. So this is a perfect segue in the afternoon. There's sessions in other room that's ethic and biased. So it's very good. And we can end early, 10 minutes back. And thank you guys. So we'll see you in the afternoon. So, but I think the topic is very similar. So yesterday we covered the big pictures of the AI in the radiation safety and health, and we talked about the AI to build a model, AI readiness, and then how do we build a model in different aspects with digital twins or the multimodalities. I think there are some things we'll focus on this session. It's very important, so we must be penetrate this one before we actually deploy to the clinic. So the topic of this session is about the uncertainty and the quantification and trustness of the AI. And so we will have, I think, 4 speakers. And so we'll get the insights from the speakers. So how do we build the trustful and uncertain controlled AI models?
Great. For those who were not here yesterday, I'm Seferino Absamea from National Cancer Institute, and part of the planning committee for this symposium. The planning committee felt that it's important to consider multiple aspects surrounding this topic across applications in healthcare, clinical applications that are of fundamental research. And so we have invited 4 speakers today who will speak on various topics of AI applications that are hopefully reminiscent of earlier talks and expand on the important themes. So our lineup for this session is Matt Rosen from Harvard Medical School, MIT, Ruzbe Jafari from MIT Lincoln Lab, Heidi Hansen from Oak Ridge National Lab, and Ji Yu from Johnson & Johnson. And so we welcome the first speaker today, Matt Rosen from MIT and Harvard Medical School.
And I guess can we start the clock so I don't talk all day long? Those of you who know me already will expect that. Well, it's not running, so I get extra time. Nice to talk to you all. Thanks for the invitation. I'm going to talk about really how machine learning enables new classes of imaging modalities and how we can sort of prepare for their role. These are my disclosures. Most importantly, I'm a founder of Hyperfine. They make portable MRI scanners. I will talk about some of that in the talk. This is all work that's been done in my laboratory at the MGH Martinos Center, and you should all come and visit me sometime when you're in the Boston area. So 20 years ago, I was really interested in lung imaging. So my student Leo Tsai and I built an MRI scanner where the patient could stand up and lay down because we were interested in studying how the heart-lung system is affected by gravity. And that was a low-field scanner, 6.5 millitesla. It was an electromagnet scanner. And we did that because it was much easier to build a low-field scanner than a superconducting scanner. We did some really beautiful helium-3 hyperpolarized lung images back in 2008. Then we promptly took the experiment apart and I moved to the Martinos Center. So, I said that I was doing low-field MRI because it was easier. Popular Science called me the do-it-yourself MRI scanner. That was sort of a fun thing. But in 2010, after conversations with the DoD, I realized that there's intentional reasons to operate at low field. If you're interested in taking the MRI scanner outside of the controlled access environment of a radiology suite into the battlefield where there might be undisclosed shrapnel, high field MRI scanners are potentially deadly. This isn't about cost, this is about safety. And so we spent the next few years sort of doing a whole suite of acquisition strategies and coils and interesting MRI physics and signal acquisition processing things that served as kind of an existence proof as to what was possible at 6.5 millitesla. And what it shows actually is that, in fact, low field operation enables MRI everywhere. So on the left, you can see the 64 millitesla hyperfine scanner. Note there's an order of magnitude difference between the scanner in my laboratory at 6.5 millitesla and the hyperfine scanner at 64 millitesla. That MRI scanner shown there in the neuro ICU at the MGH, is on wheels. And again, imagine a high field multi-Tesla magnet on wheels. It would be quite dangerous, if not funny for a few moments. Science has picked up that this is sort of interesting, talking about MRI for all. These are, of course, inexpensive machines. And even the MRI Society at large has sort of realized that this is a real thing. The ISMRM had a workshop on low field MRI in 2022. And I think most telling, the ISMRT, the technologists workshop meeting, had me as a plenary last year. And I think for the purpose of this meeting, I want to talk about some applications that honestly benefit from operation at low field, not like a science fair experiment. And these all exploit strategies that leverage compute and per se machine learning. So you can't just turn the magnetic field down in MRI and expect to make good pictures. That's because we use inductive detection to detect the vanishingly small nuclear polarization of water protons in the body. Magnetic moments are very, very small, what Richard Ernst talks about as the powers of evil in NMR. So the only thing you can do is turn up the magnetic field to make nice pictures. What sort of images do you think you would make at 6.5 millitesla, 0.0065 Tesla? That's about 500 times lower magnetic field. It's about 10,000 times lower SNR. Well, you'd probably expect you'd make images like this. This, if you believe it, is a human head that was acquired back during the time where we were doing helium lung imaging. It took about an hour to acquire and nobody cared. So we've been working in my lab about solving a hard problem, enabling MRI at ultra low field through a combination of physics and compute. And the physics strategies are really about maximizing the signal to noise in your detector. So the way you interrogate the system and the way you measure it, and then using compute, once you've acquired that data, to get more information, or as the kids call it, fix it in post. And deep learning strategies have really emerged as a very essential part of that. So prior to deep learning, we published results like this. We were very impressed. We were doing 6-minute acquisitions at 6.5 millitesla. We could do full 3D imaging through a combination, again, of acquisition strategies and hardware. And compare that again to the slide I just showed you. This is acquired on the same scanner, right? But we were doing things correctly. So then, we were kind of at a place in my lab where we were out. We were at the Johnson noise limit on our detectors. Our signal acquisition strategies were maximally efficient. And so, the joke in my lab, sort of Beaujeu, my postdoc at the time, said, we can no longer improve the signal. Can we just somehow delete the noise? And so we took this very seriously and thinking about how do you acquire and reconstruct data in any imaging scanner? And this is relevant to everybody, not just people who do MRI. So you have an object and you forward encode it into, let's call it the sensor domain. That could be radon sinogram for PET CT. It could be element time space for ultrasound, and it could be Fourier K-space for MRI. That's called acquisition, right? Then you reconstruct it. That is, you invert the forward encoding, right? Now, that gets you your image. Now, specifically in MRI, what is the encoding or forward model? That's the signal. And you can write down the signal. Remember, we use NMR to detect the signal, which I've just written down. And then we phase and frequency modulate that NMR signal by the application of magnetic gradient fields. Well, you can tell, I think the laser pointer doesn't work that great. I've just written down in mathematics what I said in words. And we all, of course, recognize this as the Fourier transform, right? So the sensor domain in Cartesian MRI is the Fourier domain. And we know how to invert that. You just do an inverse Fourier transform. We've been doing that since we were in second grade, and that's reconstruction. But since the early days of MRI, there have been all sorts of different ways of encoding and reconstructing. And those things are quite complicated. Some of them are non-analytic solutions, and they require iterative reconstruction. Those of you who work in nuclear medicine are quite familiar with this. So you end up with a whole zoo of reconstruction where each one of these things is a colored box. Now, the brain does a much better job at handling noisy data, separating signal from noise, right? Our biological neural networks have been trained since birth on what makes an image, edges, patterns, texture versus noise. And if you don't believe me, what animal is this? You all knew immediately it was a dog. Interesting, because I violated the Nyquist criteria, right? I showed you less than half the data, but your brain has seen many dogs in its lifetime. Maybe not that particular dog. And now in the language of signal processing, you've gone from an undersampled or low SNR image to a fully sampled or high SNR image by hallucination, right? Your brain hallucinates the final perceptual image from the learned sparse convolutional kernels. So This was again work led by Beaujeu in my lab. We published it in Nature in 2018. This leads to our deep learning for image reconstruction approach, AutoMap, automated transform by manifold approximation. And the idea is basically to learn to invert an arbitrary forward model. And it does it by identifying sparsity in both domains, that is the signal domain and the image domain, to improve SNR and accuracy a la perceptual learning. This is very different from a convolutional neural network denoiser that many of you are familiar with, which is basically noise training. So you give pairs of noisy data and clean data, and you learn the noise. In this case, we learn on clean pairs. So if we're doing, let's say, forward encoding in Fourier space, we take an object, a cat, a dog, a bird, a mouse, a flower, images from ImageNet, and we forward encode them into what they look like in the sensor space, and then we learn to invert that encoding by example. And then the noise immunity, the boosts in signal to noise, emerge naturally in the same way biological perceptual learning works. Now, I talked a lot about sparsity, and just very, very briefly, sparsity is a way that we can separate signal and noise can be anything. This is a 128 by 128 image, so you can have a 2 to the 128 squared possible images. Natural images are special, right? They have structure to them. And so the idea is that high dimensional data, like a 128 by 128 object, can be represented with less coefficients in a sparse domain. And it's not, so images are not sparse in the image domain. They're also not sparse in the Fourier domain. It's funny, I said this whole thing about the brain operates and learns sparse kernels. What's sparse about images? Well, as an example, if you transform to a domain like the wavelet domain, right, which is very featurey, images are in fact sparse. And this is really the same way that AutoMap works. It identifies these sparse domains. So AutoMap, again, this is not a talk about AutoMap. I just want to kind of give a sense of how this works. The raw case-based data comes in one side, the reconstructed images come out the other side. This is from the 2018 Nature paper. What I want to show you is that, that's fun. What I want to show you is there's a reference clean image on the left side. I was going to use the laser pointer, but I don't think it works very well. And then those have been forward encoded with 4 different types of encodings: radon, spiral, undersampled Fourier, or echo shifted EPI. And in all cases, the middle column has a SNR that's factors of 2 to 3 above the conventional reconstruction, some of which are highly regularized and iterative reconstruction approaches that many of you are familiar with. So I started out by talking about low field MRI. What happens when you give it noisy data like we have at low field MRI? You get boosts of something like 1.5 to 2.5, depending on the details. If you look over here, in the places where the source SNR is low, you get bigger boosts. In places where there's a lot of SNR, the boost isn't so much. Again, the algorithm is filling in the missing data based on the learned convolutional kernels and the sparsity in both domains. So you get these nice SNR boosts. What I've highlighted here, I don't know if you can tell, but there's what's called a zipper artifact. The scanner was misbehaving on that particular day. So the pixels go from black to white to black to white. That's gone in the neural network reconstruction, which is curious because I didn't train this to eliminate artifacts. I trained it on sparse properties of natural images, not even brains. Cats, dogs, birds, and flowers, which have more in common with images of the brain than noise does. So why did the artifact get deleted? Well, in fact, if you think about the sparsity of an artifact that goes black, white, you don't generally see that in nature. Okay, a zebra aside, but you don't generally see pixels rapidly, intensely modulating. So again, that eliminates some stuff. Now, about the topic of this talk, right? Your brain, or now your AI network, learns to do this transform by seeing many examples, and it hallucinates, right, the final image. That's a statement of fact. So the fear is that AI-based reconstruction methods, they might not see your tumor, right? You've all seen this before, Chihuahua or muffin, right? This data is pretty interesting. The reality is reconstruction solves a very well-defined math problem. Okay, and we're solving an inverse problem. These are well-described, difficult math problems. And we condition the solution to that by training on the forward encoding of various types of data, none of which are your tumor, sorry. Okay? And so it's very, very different from saying, oh, I'm doing super resolution on an image domain, I'm sharpening, I'm doing this, I'm doing that. We use mini batches, we train the network to basically recognize this domain transformation. A very, very different kind of problem. Now, it is certainly true that your training corpus matters. So here I'm showing high B-value diffusion data. And look in the right column, B of 3000. It's very, very noisy data, acquired at 3 Tesla. Here's a Fourier transform. It's pretty noisy. Here is the same data reconstructed with a neural network trained on brain-weighted, T1-weighted brain images. And then here's one trained on a more domain-specific diffusion-weighted image, and you get better performance. So the deeper in domain your training gets, the better the identification by the network of the sparsity, and the better denoising or separation of signal and noise you can get. In the worst case, if you train on cats and dogs and birds and flowers, it performs just as well as the Fourier transform. So this type of math problem solved with neural networks is kind of particularly immune to this kind of issue. My former student, Daniel Buto, published a nice paper about parameterizing training network bias and hallucinations and uncertainties using a local Lifshitz distribution. And so you can see in some of these images, we're doing error maps. So different types of reconstructions of the source data. And this uncertainty map, which is well described in this paper, I recommend you take a look at it, shows you places where, in fact, that the reconstruction is unstable to small perturbations, which generally could lead to out-of-band errors and helps you parameterize the bias. Okay, so my motivation 10 minutes ago was you can take the MRI scanner out of the controlled access environment. This is the hyperfine scanner in the Yale New Haven Hospital Neuro ICU during the heart of the pandemic in 2020. You'll notice something you maybe have never seen before, an MRI scanner at the bedside of a comatose patient on a ventilator, right? Only possible because this is an ultra low field system. These are images acquired from patients at the bedside. I am not a radiologist, but I sure can read this, right? So these were comatose patients, and they were able to essentially do neuro exams without having to transport them to the radiology suite and take them off the vent. Very interesting. This technology continues to be useful. Me and my clinical collaborators, led by Kevin Shea at Yale and Taylor Kimberly at MGH, both clinical neurologists, continue to publish a bunch of this work and in interesting locations. And now there's another aspect of machine learning which I want to talk about. I did mention super resolution, kind of casually throwing it off early on. I want to talk about this. So on the left is a bedside MRI of a patient. On the right is a 3 Tesla MP RAGE, same patient. In the middle is a synthetic super resolution approach. This is work led by my co-director at the Center for Machine Learning at MGH, Eugenio Iglesias. This image in the middle looks awesome. But for those neuro-rads in the audience, and even just the eagle-eyed Where's Waldo fans, these images are different, actually. Even I can tell that, right? So what do? Because we care about accuracy, we care about uncertainty. Well, we use this not to make accurate in-plane images, but to make derived segmentation maps, quantitative volumetric morphological measurements of tissue that are enabled by operation in this higher resolution space. And so the thing we care about is the accuracy of the segmentation compared to high field. Now, again, the fear is that these super resolution methods might not see your tumor, or it might create abnormal pathology. The reality is, in fact, well-founded. This is work from a friend, a colleague, Ed Wu at the University of Hong Kong, that got a lot of acclaim back in 2023, work he did at 55 millitesla. So here are his acquired images on the left, high field on the right, super resolution in the center. I will point your eyes to the circled regions. Again, these regions are very, very different. This is definitely creating pathology, okay? If you're trying to use these super resolution images for diagnostic purposes, you better be careful. And in fact, Twitter went crazy about this. This is a good one. These are all MRI researchers. Try it on Pluto next, right? Sort of pretty funny, actually. I agree. So I said, well, we're doing quantitative work and we're careful about this. And so these tools, in fact, have their place. It is true that when we do super resolution, we explicitly in-paint pathology because all we care about are the edges. We're trying to make quantitative volumetric measurements of tissue. And in fact, compare this to work done at 3 Tesla, it looks pretty good. Again, this is very comparable to the ground truth. we're doing quantitative morphology. We have ways to check that, at least until these algorithms are well established. What can you do with now adding super resolution and quantitative morphological measurements at low field? You can do some really cool stuff. This is work led by Annabelle Sorby-Adams. She's a postdoc in my group. This was published in 2024 in Nature Comms. So these portable scanners, you can put them in the memory unit, for instance, at the MGH, and you can scan patients who are coming in because their caregiver, typically aged matched spouses or family members, are noticing cognitive impairment in these patients. And so we can scan them. It's very easy, it's very comfortable. And so what's shown here in the top on the LF is low field, T1, HF is high field, 3T, and then FLAIR. So there's T1 and T2 weighted images acquired at the bedside and at 3 Tesla. And the images that are shown here are the, sorry, I gotta make sure I'm telling you the right thing, are the super resolution images. And then we run our validated segmentation approach, which I just showed you. And we're showing here below both high field and low field volumetric maps of hippocampal regions, ventricular regions, whole brain, and the white matter hyperintensity lesions. If you look at the data shown here on the right, well, let's look at the top. Again, accuracy of these algorithms has been getting better and better. That is low field versus high field. So ideally, you'll be on the y equals x line here for truth. And then below, you'll see in the different patient cohorts, we've got reductions in hippocampal volumes in the AD cohort, increases in the ventricular size, shrinkage of the whole brain, and higher lesion count in that population that's had AD compared to non-degenerative diseases. Okay. Oh, I'm way ahead of myself. We can slow down. Oof. So before now, I showed this slide earlier on, and I talked about reconstruction as solving this interesting math problem using machine learning. And then I diverted a little bit to talking about image-based things for quantitative morphological measurements. This meeting isn't so much about MRI. I know that there's people from the nuke med space. So I wanted to talk about this other part of the problem. If you're doing imaging, broadly speaking, and you have some object and you're trying to forward encode it, there's all kinds of ways to do it. In X-ray CT, we typically do centric encoding or radial encoding. There's all kinds of things that are possible. And so I was looking at this the other day. There's, in the field of engineering, these ideas around optimized design. So what's on the left here is some cable support structure, and you run these sort of evolutionary, algorithms. They take away material, but they keep the thing as strong as it was before. Kind of amazing. Unless you think that this is just for like cable supports. NASA did this for a spacecraft antenna. Now, I'm a physicist. I'm not an RF engineer. I do dabble doing RF design, but I guarantee no RF engineer would design this unless they sat on it by accident, right? This is completely insane. But in fact, you end up in this optimized space because of these search algorithms are so interesting. So why do our encoding mechanisms, in MRI look like this, right? For those familiar with MRI, there's Cartesian. Ooh, some people do spiral. It's kind of a West Coast thing. And then radial, right? Why? Why do we only do those things? The reason is, of course, because pointy-headed physicists like me know how to do a Fourier transform and not much else. And so, the idea is that now we have hardware, right? This thing called AutoMap, which can learn to invert an arbitrary forward encoding. So let's come up with some arbitrary forward encodings. Maybe we could change the world or cut scan time, by 50% or better. And there's a couple ways to do this that we've done in my lab. One is a model-based computational graph approach. So we know the equations of motion. We know the block equations for those who are familiar with NMR. You write it as a computational graph. The beautiful thing is, of course, backpropagation, stochastic gradient descent, essentially is doing symbolic differentiation, right? So you can solve all these kind of problems super fast. The problem that this experiment was asked to do was sort of discover the spin echo. So this basically came up with like this sort of zeroth order way of doing magnetic resonance. It doesn't look like anything I understand, but it works. Maybe more understandable and sort of more fun is a model-based, a model-free reinforcement learning approach. You've probably all seen this now. It's quite old. Google DeepMind taught a AI to play Tetris, not by teaching it the rules, but basically by saying, here's the pixels on the screen and here's your score. Do whatever you can to the inputs to maximize the score. And if you watch this for a while, this algorithm comes up with a really interesting strategy of basically tunneling up, I think it's the left side of the screen after a while, to like maximize the number of points, or the right side of the screen or somewhere. Yeah, there you go, wham, right? And it learned this after many, many iterations. Again, that'd be cool to do that with an MRI scanner. So we built a little thing where we had an MRI simulator shown here and an AI agent whose job it was to basically say, these are the ground truth digital phantoms. Here's what they look like encoded using the sequence you've told me, then inverse Fourier transform and compare them. So come up with a cool way of doing MRI. And in this case, we asked it to do it in the presence of some weird and unknown to the agent quartic third order magnetic field variation in the background. And it came up with some cool way to do slice selection. That's kind of an interesting thing. Just sort of to close with some examples, this works because this talk is about uncertainty. And I'm dodging this uncertainty thing by saying, oh, we're solving math problems, we're doing quantitative things, everything we do is checkable. And so here's another example of that. This is an NMR experiment. This was done at 6.5 millitesla. I took a 2 milliliter bottle of something and I put it in the scanner. And I should say that the AI algorithm was tasked with the question of measure T1 and T2 in 1 second, and you can play 100 pulses, whatever pulses you want. If you're not familiar with T1 and T2, those are magnetic relaxation properties of the material we're under investigation. Typically, you come up with a sequence that takes anywhere between a second and 20 minutes to measure this, depending on the details. So I said, you only have 1 second, play whatever you want. It came up with this weird amplitude and phase table. Oh, here's the scanner with the sample in there. 2 minutes. Yes, perfect. Here it says 55 seconds, so we're in good shape. We ran that sequence for 4 different samples. We get different spin isochromats here. This data is all different from each other. Who knows what it means? I can't analyze it using a single fit exponential because the forward model was some wackadoo thing. But I can use a trained neural network regressor, right, which we call drone, and it gives beautiful data compared to the ground truth. So this is T1 and T2, and interestingly, the error on T2 is better than the error on T1. For those who do quantitative MRI, this is almost unheard of. And so this is sort of an interesting thing. Okay, so in conclusion, I think I convinced you, and I don't have to twist people's arms like I had to do 10 years ago. MRI is in fact possible in the millitesla regime through an interesting combination of physics and compute and increasingly deep learning. I talked a little bit about AutoMap, which is this unified reconstruction framework that is trained on the forward model, learns how to solve arbitrary inverse problems, and boosts SNR by operation and learns sparse bases. I showed how super resolution plus segmentation can give you these interesting volumetric measurements that are actually more robust than the planar images, which can be suspect. I very briefly showed you an example of AI pulse sequences. Just to close talking about low-cost MRI, I'm not a physician, but Steve Schiff, who's a pediatric neurosurgeon at Yale, has said low-cost MRI can revolutionize medical care. In my own career, I've been construct and reconstruct MRI systems, and now increasingly using deep learning in ways that I thought were interesting. I'd love in the after yourselves and some of these reconstruction tools. I have to acknowledge my group, all the students and postdocs and increasingly junior faculty. I have to say that is the include people who are faculty, who were promoted from postdocs and all the funding agencies. And thank you all so much.
Thanks very much for a very high energy talk. Our next speaker is Rusbeh Jafari from MIT as well, but the Lincoln Lab, on case study of blood pressure modeling using physics-inspired neural networks.
Thank you so much. Nice to see you all, and thank you for the invitation. I'm presenting this work on behalf of my team. Consell, he's a postdoc at MIT, and then Dean Altman, he is one of my team members at Texas A&M. I have multiple appointments at different locations, but my main appointment is at MIT Lincoln Lab. So today I'm going to talk a little bit about digital twin. I'll start with an introduction. Then I will talk about the concept of scientific machine learning or physics-informed neural net connected to the specific sensing modality that we have. I'll talk a little bit about the modeling, and then towards the end, I demonstrate some of the results as it pertains to trustworthiness and the concluding remarks. So the premise of digital twin is the virtual representation, right? So we have the virtual representation, but the virtual representation needs to reflect on, in the context of health, it needs to reflect on our human body. So that's the second component, which is on the left, which is the physical counterpart. We need to have sensors, and then we need to be able to connect the physical representation to the virtual representation using sensors and some of the machine learning algorithms. So that's the third component of the digital twin. And the fourth one, which arguably is the most important one, is the flow of information from virtual representation back to the physical representation. That's all about prediction. I want to know what would happen to me in future if I happen to take certain actions, right? And then in the middle of it, we have human in the loop, stakeholders, those who are using this information. How can they turn it into actionable information? So with that in mind, building the virtual representation with the right fidelity is one of the most important questions as it pertains to the digital twin. There are different ways you can do this. This is where the notion of modeling comes into the picture. And sometimes when people ask me, so is digital twin the same as simulation? Well, it uses some components of simulation, but it has to remain tightly coupled with the physical world. That's the catch of it, right? You also might have heard this term. They say all models are wrong, some are useful. So the question is, what level of granularity are we going to use? How are we going to construct the models? And how do we make sure that our models are actionable? How we can make sure that the models provide trustworthy information to us? So my passion for the field is we got to be able to build the concept of models from images, bottom up, at the highest fidelity. MRI was one of the discussions we talked about today, CT scan, ultrasound. Today, I'm going to talk about a different kind of modality, which is based on bioimpedance, and it's sort of a wearable modality, but that's what we're going to focus on today. So when we build the models, oftentimes the issue becomes we understand the physics of the model, but we cannot really estimate all the hidden parameters of the model. And that's one of the problems that we need to solve. Some of it needs to be in the form of parameter estimation. When you have an image and you take the image, you want to create the physical representation of that image, you can extract all the parameters from an image. You can, in fact, extract about 5 to 10%, right? And then the computational demand of these models also become a problem oftentimes. We'll briefly talk about it. So one idea is, can I use the notion of scientific machine learning, a type of machine learning that instead of learning the patterns of data, it would learn the laws of physics? Can I use the scientific machine learning to serve as a proxy for this model? And that's what this talk is going to explore. Scientific machine learning looks at, again, learning the rules of physics. It's a mechanistic model. It focuses on causation, whereas the statistical approaches learn the patterns of data. What that means is if you haven't seen certain parts of data, then you would not learn it, right? And that's one of the limitations for digital twin, because by definition, I'm trying to build a digital twin for myself that would predict certain adverse cardiac events. I have not seen that data. So this is where the notion of physics-based models would come into the picture that would provide the predictive power. The key opportunities are establishing physical consistency and constraints, satisfaction into the model, do uncertainty quantification, come up with interpretability, explainability. If you happen to have the physics, I'm going to show you that you can actually explain the behavior of the model. It would help with generalization and robustness. It would help us with the data quality. If the data quality is poor, the model is not going to respond to it, and we can quantify that. And then it helps us with the domain-specific validation benchmarking. And then eventually you can have hybrid version of these models. You can have physics-based models. You can have simulation that are cross-referencing each other. Simulation is more accurate, but it's much more expensive computationally. And you can combine them. And all of these would sit as a part of the trustworthiness. Now, today, what I'm going to talk about is I'm going to focus on these 4 elements in the context of our application. So I don't mean to review Physics 101, but there is a little spring I have, and the spring has a damping factor. It's oscillating, right? And I want to figure out where my mass is. If I happen to know the equation, I can write it and figure out where my mass is. But let's say I don't have the hidden parameters there, the damping factor, the mass, as well as the constant coefficient of the spring. So what I'm going to do is I'm going to build a basic, simple neural net that would try to estimate the behavior of the spring. And what I'm going to do is intentionally, I'm going to apply data from all the way to the left to the point that you see, right? And then the neural net would try to minimize the error. The neural net has no idea you have a spring, and that's why you get that kind of behavior, right? Now, if I happen to take the model of the spring, right? And if I apply this in my loss function, which means that I'm going to try to minimize my error subject to that loss function, now the neural net understands that you have a spring and it can provide good prediction. So that's the whole premise of the physics-informed neural net. And I'll talk about a couple of existing work. This has been looked at. The area is for medicine is fairly new, but it has been looked at in the context of clinical image data. It has been looked at in the context of measuring certain hemodynamic parameters and then also modeling the Navier-Stokes. This specific pieces of work that I showed you all require access to clinical images, and the approach that I'm going to present today doesn't have that requirement. So today, what I'm going to talk about is that we're going to talk about a specific wearable sensor, which I'm going to introduce in a second. The wearable sensor doesn't give me all the hidden parameters that I want to capture. It sort of provides a proxy, but I'm going to show you how you could actually use the physiological models, in particular Wien-Kessel models, to be able to estimate some of those hidden parameters. And the contribution is going to be both personalization as well as building interpretability of the models. So the PINN sits in the middle. Again, there are models on the right-hand side that would drive the model, the PINN. And then I have a number of sensors, wearable, more in the form of ambulatory sensors that would drive the personalization of the models. At the end, I'm going to talk a little bit about some of the liberal PINN and some of the future directions. So let's talk a little bit about the blood pressure. Blood pressure is holy grail in medicine. It's the most important metric that cardiologists use. And it can provide very important information about the risk of cardiovascular health. A large number of Americans suffer from hypertension, and there are different versions of it. There are types of hypertension, which is called white coat syndrome. You see a physician, your blood pressure goes up because you get nervous. And there are other types that are called mask hypertension. When you take the measurements, your blood pressure is not high, but at the time that you want to take it, you don't take it. I also have a feeling that the way we measure the blood pressure is not correct, but that's a different topic. So why blood pressure is so important? Let's just do a quick review of the physiology. So at the center of the cardiovascular system, we have the heart. Heart has a heart rate. With every heartbeat, there is so many milliliter of blood would leave the heart. That's called the stroke volume. Combination of those two would give us the cardiac output. Cardiac output is sort of the power of the heart, how much blood leaves the heart. But the amazing part about our cardiovascular system is when the blood leaves the heart, it doesn't enter these solid pipes. It enters vascular system that have compliance or resistance. It is about cardiac output, but it's more about the stiffness of arterial wall. When you get stressed out, the arteries become stiffer. And if this happens over and over time, it becomes a chronic stress. And over time, the heart becomes has to work hard, so cardiac output goes up. But really, what we need to measure is the stiffness of arterial wall, but pressure gives us a continuous waveform, just like what you see. minimum value called diastolic blood pressure, maximum systolic, and the waveform itself has a lot of value. We can measure the waveform right now. The technologies are very challenging, but there is so much information in that waveform that would be diagnostic. So the blood pressure waveform is driven by what is so-called Wien-Kessel model. The Wien-Kessel model would define you have a blood flow that leaves the heart. It enters the artery. The artery is going to resist towards accepting the blood. It also has a compliance. The resistance in electrical networks, electronics, is more of a resistance. The compliance is more of a capacitance. And you can model this and you can write the equations. We understand that, but what we don't understand is these models are not personalized. In order for this model to become actionable, it needs to be personalized. So there are different ways you can do it. Wien-Kessel has multiple configurations. I'm using one of the simpler ones. You have the characteristics impedance of the arteries, you have the arterial compliance, you have the peripheral resistance, and then you can make assumptions about how you want to build this. You can set the parameters at the participant level fixed. You can make a decision to vary the parameters based on every beat, or you can make a decision to extract those parameters from additional imaging modalities to make it more customized. And I'm going to talk about those today. So there are two different models that I'm going to use. Wien-Kessel model 2-element, which is on the left-hand side, and Wien-Kessel model 3-element, which is on the right-hand side. And I'm going to represent them with these little icons, and I'm going to show you how they work. So this is an example of a Wien-Kessel 3-element, which we use for the physics-informed neural net. As I mentioned to you, what we need to do is we need to apply the penalty function into our loss function, which we do. We also take into account some of the characteristics of the participants: age, sex, height, and weight. So we construct this. The loss function has two components. One part of the loss function is the data, because you're using data to train the network, and you try to minimize the error. But then the other part of the loss function is loss function due to the physics. And both of them are shown here, L of data and L of residual. And you optimize your neural net based on the objective function that we have. The specific modality that we're going to use today as a part of this is we have 3 NIH-R01 supporting this work, is that we've been using bioimpedance. Bioimpedance is based on 4-point sensing, Kelvin sensing. You inject a current, you measure the voltage, you measure the impedance of the tissue. There are certain important properties and features for bioimpedance. When we are measuring the blood volumetric changes and hemodynamic parameters, we have to get to the arteries. In order to get to the artery, we have to travel about 1 centimeter, or we have radial as well. Get to the capillaries, which are very small vessels using optical modalities. Unfortunately, we don't have pressure there, right? So the bioimpedance can address that problem. It can go deep into the tissue. If somebody has a higher BMI, it can still work. Also, it's not sensitive to the skin tones. Optical modalities are sensitive to the skin tones. It is notoriously susceptible to noise. So the specific use case that I share nocturnal, which some of us talked about during the dinner. Ring form factor, watch form factor, electronic tattoos. I'll show you some of these examples. So this is one of our recent work where we used graphene-based sensors. We placed them 4-point sensing at 2 different locations, and then we measure the characteristic signals. We also measure the timing information between the 2 signals, the pulse transit time. We have to introduce changes in blood pressure. We do it by introducing exercise, cold pressure. You place your hand in an ice bucket to the extent that you can take it. That's vasoconstriction. Your blood pressure changes. And then we continuously measure the blood pressure using a phenopress machine that gives us continuous measurement. We also measure it from our system. So when we wanted to talk about the context of Wien-Kessel models, one question is, how do I train my model in a way that it would be fair, right? So what we did was we took all the data points that come from the blood pressure. This is a systolic blood pressure, range of 100 to 140 in the presence of maneuvers. And then what we did was we took the bottom and the top of the data to train the model. The assumption was that we kept the middle not available to the training, right? The assumption was that if my model learns the physics of it, it should do a good job for the middle too, right? Because it looked at the 2 extremes. And we tested it on the 70% of the middle data points. It actually turned out to work really well. The green is the values that come from the PINN, and the CNN is a vanilla neural net. You can see that obviously the error is better, but what's more important is it works better for extreme conditions. And that's because we learned the physics of it, right? We can also do waveform estimation. The specific blood pressure device that we use, PhenoPress, gives us the waveform. It comes from the finger. And the PINN works a lot better depending on the specific modality, and then it doesn't overfit. And then this is really the interesting part and the important part of it. You know, when we look at certain disorders, like again, when I introduce chronic stress, when I introduce even hemorrhage for combat casualty care, right? So many things are happening at the same time, right? When somebody is wounded, what happens is you lose the blood fluid. Cardiac output goes down. Now the heart starts compensating for that. So the blood pressure has to go up, the vasoconstriction goes up, the heart rate goes up, the tachycardia, and then eventually things start going in the right direction. But what really remains elevated would be the peripheral resistance, right? That's the metric that I want to measure. I don't want to measure blood pressure because blood pressure is not giving me the causation, it's giving me correlation. So with these approaches, you can actually measure things like peripheral resistance, arterial compliance. This is for 18 to 26-year-old. If you look at my arterial compliance, I'm in mid-40s. My arterial compliance is a lot less than that, right? And this is really the metric that we want to be measuring. In terms of understanding the interpretation of this, you could look into things like, you know, the characteristics impedance with the blood pressure in the presence of a specific maneuvers. Cold pressure is a pain mechanism. You would be able to characterize this. These are some of the examples of, again, we take the physical constraints, we take the loss from the physics, and then we build the neural net with a combination of the loss on the data as well as the loss coming from the physics. And the interesting part is when the model is working well, the confidence on the physics side is going to be higher, and that gives us an indication on the trustworthiness of this. We need more work to be done at this on this topic, but we're going in the direction of showing some of the confidence coming directly from the physics of the neural net. So there are other things that we should be looking at and we haven't looked at necessarily. You know, there are different sources of noise. We have the noise coming from the specific data, noise in the bioimpedance that needs to be modeled. There is uncertainty associated with estimating the parameters. Some of those parameters can change when you look at, for example, different kind of maneuvers, cold pressor to exercise, the underlying mechanisms are different. And then there are additional uncertainty with respect to the hemodynamics. One thing that we didn't model as a part of this study was the reflection of the wave. When the blood pressure is traveling, it gets to the end of the artery, it comes back. That also needs to be incorporated into the model. And then the PINN also needs to be liberal. We should let PINN figure out how the parameters change from beat to beat. So with that, I'm going to conclude. The real-time update of virtual representation for digital twin is the key. Prediction is arguably the most important feature of the PINN, and we want to be able to train the models that we have, the virtual representation, if they are based on PINN, based on the rules of physics and physiology, as opposed to the data itself. And the graph that I have on the right-hand side is really our aspiration. You know, oftentimes when we think about the risk factors has a really wide aperture because we can't really determine exactly what's happening. We want to be able to reduce that and provide a trajectory in terms of how good that intervention is. So with that, I'm going to close and I look forward to our panel discussion.
So the next speaker, Heidi Hansen from Oak Ridge National Lab. Her talk will be assessing uncertainty in the radon exposure estimate implication for the radiation epidemiology. Thank you.
Okay, I'll go ahead and get started while my slides are getting pulled up. So I'm going to give you a couple of priors just so that you understand how I am thinking about the problems that I'm going to describe to you. In the US, lung cancer screening is done based on smoking history. Radon exposure is the second leading cause of lung cancer, and that's not factored into our recommendations for patients to undergo screening. We completely ignore that. And part of the reason is because it's very hard to measure exposure to radon. And I'm going to talk through why that is and what kind of things we can think about going forward. The other prior that I want to give you is I am very much of the belief that the way that we engineer our features in our data matters. And I know there's some interesting arguments against my statement. I'm always happy to have those discussions, but I'm going to talk to you a little bit more about the data and feature engineering and how that might affect the estimates that we're getting. And I know some people get bored when I talk about data, especially students who want to learn ML, AI algorithms. They don't want to think about the data. And I'm going to tell you, I think we should be thinking about both. So residential radon exposure, if I could design something perfectly, what I would design for the clinic, so this is precision medicine, is something that the doctor can pull up and say, okay, this is an individual's radon exposure across the life course. The way that we assign those estimates right now, we use residential location, we use indoor radon metrics for that residential location. And hey, by the way, we don't even have those estimates across the full US. So I come up with some way to model what that indoor potential might be, or some way to model what I think the indoor radon exposure might be for that individual. And there's a lot of error that goes into the way that we're designing these models. So yes, I can do very cool things. I can do machine learning algorithms. I can get to awesome answers, but are those awesome answers right? So throughout the presentation, I'm going to show you two different data sets. These are two different data sets that I've picked because I have access to them. One of them is from Utah, and I'm going to talk less about this data set. We're doing some more analyses with this right now, but this is point level data for approximately 60,000 residences in the state of Utah. We excluded all the post mitigation measures. And then for reasons that we just used a basement or bottom level. And I know that there are other ways to do that. I'm not going to talk about them today. The main point about the Utah data is I have the actual address where the test was taken. So I have a point location for those tests. The second data set that I'm going to talk about is a Pennsylvania data set. These are individual level estimates. So that means I have the value from the monitor that was placed in the home, but I don't have the geolocation of that monitor. The only thing that I have for that monitor is the zip code. We reduced the data set that we had. It was about 1 million, but we wanted to make sure that we had very high quality data. And we excluded everything that was post mitigation. And again, we're making the choice to use bottom or basement level radon exposures. The key difference that you're going to notice as I'm talking through this is the fact that I do not have the exact point location, and that leads to problems. And I'm going to talk about why that leads to problems. And I do want to mention that this is not work just done by me, but done by a whole group of us, and 2 of my collaborators are in the audience today. So thank you to them in advance. Okay, so a lot of people, when they talk about uncertainty and exposure modeling, they talk about temporal variation, spatial variation, and measurement variation. In fact, as you read the literature, these things come up. We all know them. We all know what causes them. But I'm going to talk a little bit about the choices that we make when we geoprocess our data and how that leads to uncertainty as well. So what you see on the right-hand side is this nice little stacked chart that one of my colleagues made for me. And when we're dealing in data from spatial data and data that we need to create these prediction models, so your soil concentrations, your information about housing characteristics, your information about the water table, elevation, etc., what we're really dealing with is data that comes in many different shapes and sizes. So I've got a really big problem stacking different polygons. Not everything comes into the point location. And so because that happens, what people generally do to make it much easier on themselves is they aggregate up to the lowest common unit, right? So if I only have estimates in Pennsylvania at the zip code level, I'm going to take all this more detailed information and I'm going to aggregate it to the zip code. That makes it easy. I've got zip code level measures on my right-hand side. I've got zip code measures on my left-hand side. I'm going to have a nice model. It's all easy. I'm going to walk you through why that is potentially a problem and then some tricks for how we might get past this. These are not final tricks. There's a lot more to do in this space. But I want you to keep this in mind throughout the presentation. So zip code level in Utah looks very different than zip code level in more urban states. So Pennsylvania will look a lot different than this, but I picked Utah on purpose because there are these huge zip codes in rural areas. So rural zip codes are based on size of population. The more rural you are, the bigger you are. Man, the bigger you are, aggregating over that space becomes very problematic. Then we're dealing with information that's coming, it's raster information. So you can imagine like a 1KM hex overlaid across the US. Then we're going to talk a little bit about population masking. And this is one of the cool tricks that we've come up with to help create better estimates. And then I'm going to talk a little bit about how we're spatial indexing everything to the hexagons to help us overcome these problems. So because talking about how we're spatial indexing is very important, what I'm going to walk you through is for Utah, again, we have these point locations. So I know exactly where the location of the house was that had the radon test. But I don't know that information for everything that I have. And so in order to get my data to a common unit, I'm going to ignore the fact that I have my lowest common unit is zip code, and I'm going to overlay a hexagonal grid over the entire space so that then I can always use the lowest level of information that makes sense and tie everything to one of those hexes. So I'm really just dropping a grid over all of my data. I know that I'm scaling up and down depending on the data set that I'm using, but these grids allow me to do this. So this is truly just a data engineering trick, right? I can do this quickly with lots of different data sets. And we do this for a lot of different environmental exposure data sets, not just the ones that we're using for these model. And then when it makes sense, I aggregate to new polygons. So it depends on the data set that I'm using and the feature engineering choices that I want to make. When it's a space that's bigger than these polygons, what I do is I assign the value of the bigger space to these polygons. Now, if you're used to working with GIS information, you're like, that's great, but also there's so many intersecting lines in here. Yeah, we know. So it's quite complicated in terms of the workflows that we developed to do this, but basically you can think about spatial averaging. If a smaller piece of the polygon fits in, when I aggregate, I account for that by weighting my averages. So as I mentioned before, traditional ways to do this, I'm going to just aggregate everything up to the zip code level. So this is Pennsylvania. Now, when you look at the elevation data, what you're seeing is that there's a lot more specificity and I'm just ignoring it. And these are for factors that matter for indoor radon exposure. So I'm just going to aggregate up to the zip code, take an average, and then I will miss very important characteristics about the data when I'm trying to predict at the household level. Now, for some application, that's fine, right? If I'm just doing an epidemiological study, I'm okay with accepting some of the error. I just want to know if there's a signal, which is going to be harder to find with error. That might be okay. When I'm thinking about what I want to do in the clinic and assigning exposure metrics to individuals, I want to be more precise because it's costly to send people to get screening. And it also is difficult for patients sometimes to get screening. And then if you know what happened with PSA, sometimes there's not a reason to do screening. Sometimes we can overscreen. So as I mentioned before, sometimes we do have to aggregate. So there are some of these characteristics that we do have to aggregate to the zip code level, or we even want to aggregate to the hex level because that's the amount of information that I have. Now, what's typically done is I generally aggregate over that whole zip code polygon. So this is Pennsylvania. I don't know my point. Oh, there it is. This is Pennsylvania. These are my zip codes. And these little white spaces are spaces where nobody lives. This is a map of the soil characteristics, so percent clay that I find within the soil across the state of Pennsylvania. And if you can imagine, if I were to place some zip code over these spaces and then aggregate up, There's spaces where nobody lives, where I'm aggregating to get an average percent clay in that area. But here's the problem, or this is why this is a tricky solution. When I'm taking indoor home radon test values, I'm only taking those from spaces where people live. So I'm not including information from spaces where people don't live. So if I'm thinking about what are the characteristics of the soil that predict something that I'm only sampling from where people live, I probably only want to include measures that are within that space, right? I want to sample my soil measures from places where people live as well. And so what I do is I population mask everything. So yeah, I have to aggregate, but I'm going to argue that that's going to give me better information than just aggregating across a space where nobody lives. So I mask out everything where there's no possible chance that I'm going to get an indoor home radon test value from that area. And then as you can see, I'm not going to show you all, I do have a table then if anyone's super curious, but I'm not going to show you all the data or all the data features that we're including here. But because we use this spatial indexing, we can easily stack and get the information that we want across all the different layers that we're putting in. So this is just one more point to kind of hit this home. This is median radon level at the zip code level in Utah. And you can see in the Salt Lake County region, which is pretty densely populated. Even when I'm in that urban area and I'm aggregating to the zip code, I'm missing all of the heterogeneity that really exists within the data. So I'm able to do this because I do have the point level locations. The other thing that I'm missing is the bias that happens when I am only using something that requires an individual to put a home radon test in their home. So what would be lovely is if I had a sensor on everybody, but I don't. And because there's selection into who actually puts a radon test in their home, I miss these huge swaths of information where these folks, because I know the Salt Lake region well, these are lower socioeconomic status regions, where places where folks are not getting sensors put into their home, and so there is no measurement there. The other thing that, so we know there are issues with our data, right? There are issues I can't solve. I'm not going to be able to get the Pennsylvania, well, I'm trying to get the Pennsylvania geocoded information, but it takes time. I may not be able to get that across all of the US. And so I'm going to accept the fact that there are issues with my data. I don't want that to stop me from learning more about my data and creating better models. So until I can get things the way that I want, I'm just going to try to do what I can with what I have. And so this is where we came up with this sort of triangulation method. So I know that there's uncertainty in my data, but I want to characterize that uncertainty. I know there are things I'm not going to be able to correct, but I really want to use multiple models so I can have an in-depth understanding of what I'm really looking at. So this is what I'm going to show you, and I'm going to show you the average model, and some people use a median, and we will show that as well. And then I'm going to show you the quantile regression and also what I am calling a volatility model. I'm stealing that from the econometric sorts of literature. And I'm going to talk a little bit about how I can combine these three models together to really give you a better idea of what's happening in my data. So at the average model, ZICTA, so ZICTA and zip code, use them interchangeably. There's small differences between them I'm not going to get into, but I have everything at a ZICTA level. That means on all of my independent variables, I'm aggregating to the ZICTA level. My dependent variable, I'm aggregating to the zip code level. And then I'm running around in forest, and I'm giving you the permutation importance to give you some sort of idea of what the most important features are for this model. And take a look at what we're looking at. It's not really surprising, but where I really want you to pay attention is to the R squared, because many people often get this thing called R square envy, where they want the biggest R square of all time. And so when you aggregate the data, you get a bigger R squared. Now, if you think about the math that underlies that, makes sense, right? I just got rid of all the variation in my data by averaging it up. And then I create a model on top of it. If I calculate my residuals between what's predicted and my average level ZICTA radon exposure, all is great. But also, if I then do this exercise where my residuals recalculated by using the individual level measure, and I have the model that was created with my ZICTA, but I calculate the residual with my individual level measures, looks a lot different. And so this is a fun one to try to convince people of, But by ignoring all of this variability in the data, I can get to something that looks amazing in terms of accuracy, but in reality, it's not. So what am I missing by doing this? So what I'm showing you, and these little gray spots are just spaces that were made because of the choices that we made to create this map. There are places where they didn't have 3 observations in the month of January. This is Pennsylvania. And what I'm showing you is a 2D map of the coefficient of variance of radon and the average radon. And what I want to point out are these areas kind of in these higher coefficient of variation, but especially the dark orange areas, where if I were only looking at mode or median, I would actually miss some of the spaces where I had a high level of radon exposure at the Zicta level. So by averaging, I really am missing some things in my data. And then you can see all of these darker spaces are spaces where there's just a lot of variability in my measures. And so that is concerning if I am trying to come up with an estimate that I want to use for precision health. So then what we did to kind of take a deeper look at this is I said, okay, well, tell me a little bit more. I want to model the variability in my zip code. And then I want to see what features, if I transform those features into variability as well. Oh, wow. Then I want to predict what features have a lot of variation, and how do those features predict something that also has a lot of variability. So what I'm seeing here is my model's telling me something very different when I'm looking at feature importance. And this is important because it can tell me what areas I should not trust when I'm looking at those average level predictions. So if there's a lot of variability in depth to any soil restrictive layer, I may not want to trust that prediction. Soil moisture may not want to trust that prediction. So it's just a trick that's going to allow me to identify the areas that I shouldn't trust when I have to aggregate to get a prediction. I only have a few minutes, so I'm going to skip very quickly through these. I do apologize, but the story here is that if I use a quantile regression forest, so I'm now predicting the distribution rather than just looking at the average, I also get a different story. So these are the features that were important in my average model, and you can see different features are coming up in my quantile regression model. This is also a main takeaway. When I am thinking about the distribution, I get very different results than if I'm only thinking about the 50th percentile or I'm only thinking about the average. So when I want to know what somebody in a zip code has been exposed to and incorporate into the clinic, I should be very cautious when there's a lot of variation in my data. So really quickly, I do apologize. Not only do I have error in the concentration side, but I also have error in measuring exposure. None of us live in our home all day, every day, in the basement for 24 hours. And so because I'm moving around, I want to be able to quantify what kind of uncertainty that I may get. And this includes residential history because radon exposure is a long-term exposure. So I'm looking at 5 to 30 years before I'm actually getting cancer initiation. And so thinking about where people have lived over time becomes very important. And then thinking about where people are moving throughout time becomes very important. And there are some fun ways that agent-based models can be used to simulate this. And that's some of what we are doing in our lab as well. So what would an average person in a space's activity look like? And then I assign that distribution of activities to people based on different characteristics. And then I can simulate where they're going throughout the day and the possible exposures that they might have throughout a period of time. So this just helps me understand the exposure part of this at a much more detailed level than residential location. And I want to thank my funding and collaborators from Mosaic, Ehrlich, and then the Lucid project, which is a smaller project and I didn't put up here. So.
So we have a last speaker of the session, Jay Yu from Johnson & Johnson, and he will talk about the AI about the healthcare supply chain resilience and the risk management.
Yeah, thanks for the introduction. And also, I know you guys stayed almost towards the end of the conference, and this topic is the very end of our session as well. So definitely appreciate you stay until the end of the session and the conference as well on Friday afternoon. So I guess, I do want to point out that my topic might be a little bit different from, my peers and their topics previously, right? In this session is, first of all, it's more from industrial perspective. As you can see that I'm from Johnson & Johnson. And also, my presentation is more focused on the supply chain side of the global healthcare system, okay? I do want to point out that difference. Hopefully, it add a little bit more diversity, right, to the overall topics, right, in this session, yeah. So let's see, what I'm going to cover, right, in the next 20, 25 minutes in this presentation. So I'm going to start with the business problem. I'm going to provide a little bit, context information, right, to help you understand the business problem, right, to provide a problem statement. And then I'm going to talk a little bit about the overall, digital solution architecture design and the data flow process to build this capability and a solution. And then I will dive into a little bit more into the AI, machine learning, and the data science model capability, right, we're trying to build, right, in this project. And of course, towards the end, I will also highlight what kind of business impact and value, right, it brings to J&J, and also even broader, more broadly, right, industry-wide, right, to our, global healthcare supply chain. And also I will highlight, what kind of key innovations and key contributions, right, different from what we used to do, right, before we invent this new platform, this new solution in this work. Finally, I will conclude my talk and also highlight a few, future directions we're continue moving towards, okay, in this area. So let me start with the context and business problem statement, right? So the purpose is really to help you understand, why this matters to J&J, and this matters to pretty much, right, all the healthcare organizations, right, operate globally. You probably realize that even starting from COVID, right, and then also a few years after COVID pandemic, our healthcare sector has experienced lots of challenges, right, in the global supply chain network. By the way, this is not even unique, right, to healthcare industrial sector. The whole supply chain crisis, right, really across all different sectors, right? For those who live in the US, right, where indication is, right, whole inflation that which partially, right, caused by the whole supply chain crisis. And definitely healthcare sector, right, experienced lots of challenges. And you can see, right, I list some kind of, supply chain disruptive events, happened before COVID, during COVID, and after COVID as well, right? COVID pandemic, right, was a big one. And then, after COVID, right, lots of different kind of, supply chain disruptive events. Some could be, climate related, right? Could be ESG, environmental related. Some could be, financial, economic type of events. Others can be, geopolitical, right, and regulatory, right, issues we're facing. So that's why, and also just put a little bit more into context. We partnered with some consulting firms like McKinsey and KPMG, right? Did some market research. Oh, okay. And we also partner with like McKinsey and KPMG, right? There's some market research, right? Specifically looking into the healthcare supply chain. And we found that based on market survey, right? Probably more than 75% of global healthcare organizations, companies have experienced supply chain disruptive impact and issues over the past few years. Secondly is also put into a business context that what kind of impact, right, it can cause to the healthcare companies, right, to pharmaceutical medical device companies. We found that, just a single global or either global or regional disruptive supply chain event, which can cause, a half billion to $1 billion revenue loss to the company, like, at J&J's, size, similar size, okay? So that's why this become, one of the top priorities in J&J, and over the past few years, we have identified this as cross-sector, cross-functional global initiative, right, to try to build a more resilient supply chain by leveraging digital AI machine learning capabilities. So I'm going to highlight what we're trying to accomplish, right, in this initiative, right? So first of all, our mission statement, right, in this program, in this initiative, is really try to build a more resilient global healthcare supply chain, within and also outside of J&J, okay, including our vendors, suppliers, right, in the whole ecosystem. And with the purpose to really kind of be able to predictively and proactively manage those different supply chain, healthcare supply chain risks. And also provide, artificial intelligence-driven, AI-driven risk mitigation action plan, both short-term, mid-term, and also long-term as well, okay? And of course, right, in order to accomplish that, right, we definitely need to transfer, right, the way how we manage, the healthcare supply chain system, how we manage those different risk factors, right, compared to the traditional ways of working, traditional how we did that, right, in the healthcare sector in the past. So we need to be able to build more kind of, dynamic, limbo, and also digitized, right, intelligent solution to be able to provide those kind of different capabilities to proactively and predictively manage those different risk factors, which may affect your global, healthcare supply chain system. Okay, so that we can still provide our timely therapies, pharmaceutical products and treatment, right, to our patients and customers in the market. How does that work, right? So the approach we took, right, is definitely we try to leverage the cutting edge AI, machine learning, and digital technologies, right? So and then we try to build a full end-to-end, ecosystem and platform to be able to accommodate, all kinds of different, supply chain risk factors. And then we intelligently, right, identify the risk mitigation resolution from there. And then, even make those recommendations to different business units, business functions within J&J, and also even outside J&J to our upstream, suppliers, vendors, and external manufacturers, okay, in our network. Okay, so how did we do that? So I'm diving into a little bit more into the methodology part. Okay, so I'm going to propose some concepts here. So first of all, we propose a number of different, we call it, quantitative risk measures or risk indexes. Okay, to build up this kind of whole framework. One concept we propose, we call it, our residual risk exposure. And what does this index do? It basically used to measure, right, the likelihood of the risk event, right, the disruptive risk event, right, which might happen, right, in the regional or global supply chain network, right, healthcare supply chain network, and also measure, right, the likelihood how that might impact your global sales, your global distribution, right, etc. for J&J. The second type of index and metric we propose is we call it, value at risk. And this is the metric, right? We try to quantitatively measure the business impact, the financial impact, right, to our value stream, to our value chain, to our portfolio. Okay, across the entire global sales network. And within this value at risk, we also propose several sub-metrics. One is called time to recover. This is basically used to measure that how much time you might need, right, to quickly recover from this short-term disruptive supply chain event. Another sub-metric we propose is called time survive. This is basically to see that, what kind of inventory you might have, right, in your supply chain network, so that when this kind of disruptive events, for example, if a hurricane, right, come to hit the Gulf Coast, or if, there's earthquake, right, somewhere in the world, right, close to our manufacturing locations, when those incidents happen, right, issues happen, how much inventory you might have, right, which you can still continue your operation, right, normal operation, your manufacturing, your production, your distribution of the products, right, so that without significant disruption or discontinuation, right, to your supply chain. And of course, right, we also try to measure, right, the sales impacted quantitatively, right, because of those different risk factors. And the last one we also propose is we call adjusted value at risk, which is really kind of quantitatively measure the vulnerability of your entire supply chain network, as well as, right, you dive into supply chain network, different network nodes, which basically represent, could be your upstream, vendors or suppliers who provide raw materials or intermediate materials, right, to J&J, as well as, right, in the midstream, right, those different manufacturing locations, including both our own J&J's, pharmaceutical or medical device manufacturing sites, as well as our, external manufacturer sites as well. And then also towards the very end, right, we also measure, how that risk, right, propagated to the finished goods, and then how impact right to the whole distribution network, right? When we try to ship those pharmaceutical or medical device products, right, to the hospitals, to the clinics, right, to the end customers and patients, right? What kind of impact because of those disruptive events? Okay. So because we really try to measure at different levels, right, the full picture in terms of the whole network, and then down to individual nodes, and then down to individual locations as well, and then at a portfolio level, and then down to individual product level. Okay, now I'm going to show you a little bit more about the whole digital platform, right, end-to-end digital platform we have built right in this initiative. So first of all, we need to because we look at entire global supply chain network, right? J&J has. So we need to look into the bill of materials flow, okay? Basically from the raw materials, right, to the intermediates, right, to API, to packaging materials, different materials, right? And then how that flows through, right, until the end products, right, the finished goods, and then even to the distribution network, right, to the end customers, to the patients. And we need to provide right full digital visibility, right, to that bill of material flow. Secondly, we also try to map our value chain, right? Digitize our value chain so that we have all those structured and unstructured data, right? Be able to use right for the next level, AI, machine learning, and data science modeling work. And then, of course, right, the core part is that we try to leverage right cutting edge AI machine learning model. More specifically, I'm going to dive into a little bit more in the next couple of slides that we use the graph database model and the logic graph, right, as the overall framework, right, to build the solution. And then, of course, on top of that, right, we do different kinds of scenario simulation, right, to simulate when different disruptive events occur, what kind of consequences, right, might have. And then we also try to, based on the scenario simulation, right, we also try to optimize the risk mitigation plan and actions we can recommend, right, to different business functions. And then in the end, right, so we try to let system, right, automatically generate the risk mitigation action plan to the business units. So yeah, I know this is a very busy slide in terms of the architecture design of the whole solution, right, the platform. So I'm not going to dive into all the granular details, just at high level, right? So in terms of data sources, right? So we do incorporate many different data sources because the reason is that, as I mentioned, right, we want to have full picture in terms of those different risk events, risk activities. So that's why we not only look at into our internal data, right? J&J internal data, right? For example, our manufacturing operational data, our procurement system data, our financial system data, right? Our legal system data, right? Also, we partner with external vendors, right, to acquire lots of market data as well, so that we really understand, right? At a macroeconomic scale, right? So hey, what kind of external financial events which might happen, right, impact our supply chain network. What kind of geopolitical issues, right, we might have, right, across the regions, across countries, right, because J&J operate in more than 100 countries, right, in the world. And also, what kind of ESG events, right, what kind of climate, what kind of environmental events, right, which we might have, right, so that might have both short-term or even long-term, right, impact to our supply chain network as well. So that's why in the very left-hand side, right, you see probably all add together, right, around 20 plus, right, different data sources. And then we fit into our enterprise-wide. Of course, we have some internal terminology, which is basically the L2 database is essentially the data lake. Okay, our enterprise-wide data lake. Okay, and then we make those different data assets, right, really reusable and scalable and leverageable, right? Data objects, right, can be used for the further downstream, modeling and the digital solution work. And then we further, right, fit into the modeling layer, right? We build a graph database model, right, as the overall structure, right, to mimic how those information flow, right? As I said, from raw materials, intermediates, right, all the way to end products, right, to the finished goods. Okay, both on the pharmaceutical side as well as on the medical device, medical technology side. And then eventually, right, based on the graph database model, we run simulation. Okay, we run simulation on top of that, right, to mimic, right, different scenarios. And then we further, do optimization, right, to try to optimize, the risk mitigation plan in terms of how to minimize the impact on my, business, for example, revenue loss, right? How to minimize impact on my disruption, right, of my, end product supply, right, to the market, to the patients. Yeah. If I dive, a little bit further into the methodology, as I mentioned already, right? So the backbone of this whole, platform, right, is really graph database model, and then which is perfect, right? Kind of like digital twin, right? To mimic, right, the physical system, right? That network system, the supply chain network system, right? To the digital representation, and then also reflect the information flow, right? From the upstream, right, the source materials, right, to the intermediate, right, manufacturing locations, right, and then to the end product manufacturing locations, and then further, right, to the distribution network, right, to different customer sites, to the patients. And then those different data, right, from suppliers and also from external suppliers and also from internal J&J systems, right, can inject into the data lake, right, which can be used, right, automatically, right, even with automatic data pipelines, right, used by the graph database model. Okay, run simulation, run optimization on top of that. And then if I dive one step further, right, into the modeling approach, right, we also have several submodels, right. So one submodel is specific, right, more focused on the parameter, estimation and optimization, right, about the network structure, okay, to mimic, right, the behavior, right, in terms of the material flow, right, throughout the supply chain network, right, in different intermediate manufacturing locations and nodes, right, to the end products. And then another one submodel is more focused, the lower left corner, right, submodel is more focused on how to simulate, right, different scenarios, right, how likely, right, those different disruptive supply chain events, right, may occur, and then when those events occur, right, what kind of impact, right, to your network, right, to your end results, right, in the business portfolio. And then from there, right, the last submodel I'm going to quickly mention is basically with that submodel we could use, right, to design what kind of risk mitigation action plan, right, we can do, right, in both short term as well as long term, right, to take, right, to manage, right, those different risks. Yeah. And of course, right, the right hand side, right, is those key objective functions or metrics, right, we proposed and we try to simulate and optimize, right, throughout whole framework, right, in terms of the value at risk and adjusted value at risk. Okay. Yeah. I know I'm running short of time, so I'm going to skip a little bit more details on the methodology side, right? Let me get to the key innovations and the conclusion. Okay. So innovation side, right? So before we propose this solution, right? In the past, right, the whole supply chain, healthcare supply chain network, risk analysis, right, was done more kind of in a manual fashion. Okay. And then also lack of quantitative metrics. Okay. So people kind of did it, right, in more kind of qualitative way. And we didn't really understand, right? It's kind of more, we were in the responsive mode, right? So we didn't do much prediction, right, in the past, right? Because that causes quantitative analysis. And then, the risk mitigation, right, is always responsive as well. Now with this, AI machine learning based, right, resilience platform, right, we have more, quantitative metrics there. And then we can also have the whole systematic approach, right, to be able to predictively, manage, right, those different risks. And then we can design corresponding, risk mitigation plan, right, how to mitigate those risks, right, in predictive and proactive manner as well. Okay, and the whole process, right, is automated as well with all those, automated, data lake and the data engineering pipelines, right, to flow the data, right, from one end, right, to the other end. Okay, let me conclude. Yeah, I'm going to skip this slide as well. I'm going to conclude my talk, right, and then just quickly mention, the next steps we're trying to still focus on, right, to drive this initiative, right, to the next level. So now we're looking to kind of try to actually we are looking to to see how to leverage, right, even foundational model, language model, and Gen AI capabilities, right, to do more kind of automated scenario modeling and simulation. And then from there, right, we try to scale up, right, a solution, right, to cover really the global portfolio. That's one direction we're moving towards. And another direction is really kind of all those individual, right, elements, right, in the whole supply chain network, right, from procurement to manufacturing all the way to the distribution, right, to the transportation, right? How to integrate all those together, right? And then with the full visibility and the solution design. And of course, right? And also we are also considering, what kind of long-term, how to provide automatic, right? So, how to automatically sustain, right, the solution in long-term, right? Also leveraging, some kind of GPT or language model type of capabilities to do that for end users. Yeah. Okay. With that, again, I would thank, for your attention and happy to answer any questions in the panel discussion session.
Thank you very much for all the four speakers. This is our last session, but they're all very interesting. So I am particularly energized by the first speaker. It was a very interesting breakthrough, I think, technologically. What I took away from it is that the combination of physics, compute, and deep learning really managed to get over the hump of really low SNR into something that is very, very useful and beneficial and low cost, even at that. Now, since the topic of this session is uncertainty quantification, in AI machine learning, we have the mantra of VVUQ. And I think you covered very much the VV part, verification and validation. I was unsure about the uncertainty quantification in terms of acceptable magnitude, so to say. How much sigma are we talking about, or what sort of formalism do you employ to make sure or to feel confident that it's good enough, your optimization?
Good enough is exactly the right question, really. I mean, if you think of the whole you can all hear me, yeah? In terms of the whole ecosystem of these like lower cost medical imaging devices, not just MRI, right? I mean, ultrasound, of course, has emerged for a long time as a less expensive option. Its image quality is different, right? And a stethoscope, you could think of as a single pixel, right? And you can use it to determine if someone has pneumonia or cardiac arrhythmia. So this idea about good enough in clinical practice, that's a question for someone other than me, but I can muse on it because you asked so politely. I mean, so when we provide okay. And again, I want to separate myself from what's in the commercial product, the hyperfine scanner, because they have their own AI pipeline and reconstruction pipeline that I'm not involved with. But what we do in my laboratory at 6.5 millitesla, we've developed approaches so that when we come up with an image, if we've used that automap reconstruction approach, we have ways to parameterize the accuracy based on this local Lifshitz uncertainty approach. I touched on it very briefly. But we have, we kind of know that our reconstruction is accurate, at least with regards to the types of things that would concern a radiologist. So for instance, it's extremely unlikely, if not impossible, that you will hallucinate a tumor or not show a tumor. What some of these AI models do is they take noise and they might embed it somewhere in the image. And so if you do statistical analysis of, on a voxel by voxel basis, those images might appear different analytically from one done, let's say, without those approaches. But from a radiological perspective, again, I'm basing this on what my colleagues tell me. We know what we're doing doesn't affect the diagnostic quality in an adverse way. When it comes to coming up, so that's for making pictures, right? When it comes to doing things like this quantitative morphological analysis, that work is pretty new. And again, that's led by Eugenio Iglesias at our center. All we can do is look at ground truths, right? I mean, again, doing inference, it's kind of a bummer, right? Because when is good enough, right? When we've done now however many n and the truth, the data seems to keep falling on the truth line. If we have some very large clinical outlier, will it break? Maybe. If someone has half a head, what will happen when we try to impose these are real things, right? If someone had massive surgical resection, will we get the wrong answer? Maybe. We haven't looked at those cases yet. We're really trying to marry, I'm sorry, this is a long answer, but we're really trying to address, sort of marry this technology, low cost, portable, ubiquitous, with healthcare problems that have not been addressed. And so, for instance, the recent advent of these interesting Alzheimer's drugs, they're amazing, but they have potentially quite large side effects. And in fact, in the prescribing of those drugs, patients have to have frequent MRI. And if you look at the potential population of people who would get these drugs, there's not enough MRI scanners in the world to screen them every month or every 2 weeks. And so, looking at that particular angle, doing serial neuroimaging, coming up with quantitative measurements of different morphological regions, the outliers would certainly tend to unfold. Sorry, that was a very long answer.
May I also relay that question to speaker number 2?
And this was a really long answer, so could you repeat the question?
You had these PINNs, and you plotted your waveforms and how it's able to model bit to bit, sort of. And my question is, this kind of modeling, you have not shown specifically the quantification of your uncertainty. You did mention parts of it, but so my question is, what kind of technique or algorithm you use to bracket that kind of uncertainty? Because as you know, the uncertainty comes from 2 sources, right? They have the sparsity of data, a very wild, it may be a wild distributed data rather than a highly peaked one, or that you don't really have a missing data, so to say. And so you have uncertainty when you're approached with that kind of scenario. So what sort of algorithm do you use to quantify such uncertainty?
Yeah, thank you for that question. As you mentioned, the uncertainty can come from different sources. You may have noise in the data, you may have missing data, or the model may not know how to treat that specific data, and we want to be able to capture that. There are different ways you could look into this. The noise in the actual data source could be looked at based on some of the models that you have on the data. You could also look at the latent space in most of these neural networks. And the latent space, the distribution of that would give you an indication if the distribution is something that you haven't seen or it's too noisy. That's one of the techniques. But the premise of this specific direction is to learn the laws of physics and the laws of physiology. The example that I provided was hemodynamic monitoring and the blood pressure. And then when we don't follow that, based on whatever reason that is, either the model has changed or the data no longer fits that model because the data is noisy. I think that's really the premise of this, that helps us to understand we do have uncertainty there and put a limit on that. Now, the actual example of the limit is one of the issues that we have in these kind of studies is we rely on experimental data, and there is so much you can do with the experimental data at this stage. One of the things that I'm personally very interested in is leveraging setup that would go beyond human subject research, and we use functionalized phantoms that would help us to build the entire physics. On a phantom, you can actually, so there are companies, there is a company called True Phantom Solutions. They build actually a model of the heart, which is from imaging perspective, that's accurate. You can put a CT scan, MRI, ultrasound. And then start playing with the parameters that I showed you, meaning that now you have the heart rate, you can change it, you can change your cardiac output, you can change your stroke volume, and do it in a thorough way. And now you can go back and build some of those models more accurately. One of the biggest issues we have in medicine is, unfortunately, unlike other disciplines that have been relying on computational sciences in conjunction with experimentation. For example, construction sciences, aerospace, you walk into this building, you know this building is safe, right? Because there are computational sciences that would guarantee the safety of this building. Is that the experimentation is a little easier. You can always start with a simpler airplane, simpler building, and build your way up. But the problem with human is you can't start with a simple human. So, but those are some of the techniques that I think we should take advantage.
Thanks for the long answer as well.
I think we'll start with the from the audience from Slido. There's an upvote top question here. I think it's general true for all the AI models. You know, as to the panel, so as you guys are the expert, you know the AI adoption is really growing, or development is really fast. You know but in other way, the regulation for the ethical uncertainties, it's actually fell behind of the AI model development, right? We have a model every day, but you don't have a policy every day. So in your view, so what's the biggest gaps in the current regulatory framework to relate to the AI uncertainty?
Really, the way things have accelerated and the condensing of time is affecting a lot of things in this space. That I don't have an exact answer for the policy changes that would be required to make sure things are okay here, because man, I can barely figure out what to do in my own group, because every day a new paper comes out and every day I'm already behind. But one thing that we've been thinking about is the fact that I'm seemingly behind every day, but not everything that's coming out is signal. It's all a lot of noise in some sense, right? So I'm dealing with how do I parse through what's real, what's fake, what's shiny, what's, you know, reasonable to do. And I would say from what should I implement in the clinic space, what should I be thinking about in reality space, that needs to stay slow enough that we can fully vet it, that we're doing all the VBUQ, that we understand what we're building. So even though things are developing fast, I might just have to decouple those things and make sure that as a practitioner, I'm fully vetting the models that I'm using. So that's not a direct answer, but that is an answer.
Yeah.
One thing. Go ahead.
Yeah, go
Go ahead. No.
Okay. Yeah, just build on, my colleague just said, right, about, maybe from your perspective, and I would like to add a little bit more, industrial perspective, right, to this question. So actually the whole, AI-related regulation, right, is a very hot topic, in the healthcare sector, industrial sector as well, because you know that our industry, right, is heavily regulated. And I do agree, right, right now, I think, the regulation is way behind, right, actual development, right, in the field, both academia and industry as well. So what do we, at J&J, what we are trying to do, right? First of all, we try to understand the landscape, right? And also the complexity here is that, regulation, right, is so dynamic, across the entire globe as well. And, Europe, right, US, China, India, right? We all have, different, regulatory, right, spectrum there as well. So for companies like J&J, right, operate globally. So the another dimension of complexity, right, is really understand the whole, global, regulatory, landscape. And then what we have been doing, right, two things, right? First of all, internally, right, we try to, based on the current regulation, right, and also our forecasting about the development in this field, right, we try to put together our internal governance model and a governance framework, right? For example, the past 2 years, right, I think the biggest investment area in J&J is, large language model and generative AI, right? We realize lots of different risks, right, related to generative AI, and the regulations right now is way behind, right? So internally, we try to, for example, data privacy, right, that's, protection, right? IP, right? Concern, all those different, perspectives. We try to have kind of, develop our internal framework, right? How to manage that. And then in the meantime, right, J&J also, heavily participate, right, in those external engagement, right, with government agencies, right, with academia, with, having those dialogue, right, with different parties, right, in this game, right? So we try to bring our perspective, right, to shape how the policy may go, right, in the future. Yeah.
We have a question for speaker one from Slido. In reducing the scan time, there is a cost for speed, especially for low field and high noise images. How would you balance, or how are you balancing this cost?
Yeah, so that's MRI is one of the most interesting modalities for imaging because you're always signal to noise limited. So you can trade resolution and acquisition time, it's up to you, whatever you want to do. You could, you have more SNR, you can go fast, you can accelerate, or you can go to higher resolution. This is true. You always want to operate at the cusp where you have just enough signal to noise, right? So it's true at low field too. And so it's exactly the same at low field. The types of clinical questions you ask at low field may have a different resolution threshold. We're doing some breast screening work in my lab. It's a new project. And we're scanning clinical subjects right now at 3x3 in plane. Clinical MR is typically 1 millimeter in plane. And so, but if you're developing a technique that could, for instance, obviate the need for X-ray mammo, right, with a non-invasive, much more comfortable, no radiation 3x3 approach that then would triage people into secondary screening if there's a disease, that's a win. So as a physicist who is devoted the last 20 years of my life to translational research, I work hand in hand with my scientist clinician colleagues to basically find out what's good enough and then sort of deal with that in our space. So it's not that different from what people ordinarily do, I would say.
Great. Question for speaker two. You showed a waveform propagation from the heart into basically the cuff, right? And you measured bioimpedance. What I learned from your talk is that bioimpedance is a more reliable parameter than heartbeat or blood pressure, so to say, because it gives you a systemic kind of understanding of arterial flow, so to say. Is that propagation just plain animation, or you have some imaging associated with it as verification?
Yeah, thank you so much for that question. So just a quick clarification I'd like to offer is that I compared bioimpedance to optical modalities, PPG, mostly the kind of sensors that we have on the back of the watches. And the distinction between this optical modality and the bioimpedances, the light doesn't travel that far. If we get the right wavelength, at most 5 millimeter, right? And oftentimes when we place the sensor here, we're capturing the pulsatile activity coming from capillaries. Capillaries are very thin vessels. You don't have the blood pressure in them. But the bioimpedances, we focus on placing them on the arteries, radial and ulnar artery, and they can go deeper into this. The example that I showed you also, we were using the electronic tattoo, and the advantage of the electronic tattoo is that once you put it on the skin, it doesn't move. And because of that, the physics between the sensor and the source of the signal doesn't change any, right? So that's what I was trying to get. Now, in terms of going back to the blood pressure, the way the blood pressure is measured with a cuff is you inflate a cuff, you start deflating it. At some point, you don't hear the heartbeat. At some point, you hear the first heartbeat. That's when the pressure of the cuff is the same as the pressure of the higher blood pressure, systolic. And then you keep deflating it. At some point, you do not hear the heartbeat. That's the diastolic. And somewhere in the middle, you hear the maximum tone. That's the mean arterial pressure. you get only one measure, right? The point that I was just trying to make was that we need to have continuous measures and we need to be able to take advantage of the waveform. The specific way, and I'm going too long, but the specific way that we use it for the phenopress, the way it works is that you place a ring on your finger, right? And then the ring has an optical sensor, has also small cuff. The optical sensor is looking at the digital artery, the flow of the digital artery. It builds a closed feedback loop in a way that the optical sensor would see zero change in the light. And the way it does it inflates the cuff, right? Exactly at the same way that the digital artery would put pressure, same as here, but it's a real-time system. And then once you get the zero flow, what that means is the pressure of the cuff at any time is the pressure of a digital artery. So that's how it works. It's a $50,000 machine, but the advantage that we are talking about when it comes to the bioimpedance is number one is you can go deeper into the tissue and you don't have to deal with all those other limitations that we talked about, right? And then the last piece that I want to share is that, again, the blood pressure sensor was developed in 1881 in Austria. But since the technology hasn't changed since then, the only difference is that we used to have mercury, now we no longer have mercury. But again, blood pressure is a really important clinical biomarker, but that's not what we need. When you exercise, your blood pressure goes up. That's not a bad thing. But when you're stressed out, if you go home, when you're in sleep, during the deepest sleep, the blood pressure needs to drop by about 20%. If it doesn't, it's a function of the stiffness of arterial wall. That's what we need to measure. And I think with the digital twin, we should also be thinking about reversing the paradigm of sensor design. In the past, we've been always in medicine, building a sensor and figuring out what we can do with that. Now, I think we should try to build a sensor that the computational models need. The computational models should drive the future of the sensor design. Sorry, you're not going to ask me any more questions.
Thanks again for the long answer. Sure, go ahead.
Can you use the
can you-
microphone?
Take the microphone.
Yeah.
Actually, I have 2 points of information. Roosevelt, what were your sample sizes for those studies?
So it varies. Typically, they are in the order of anything from 20 to 50.
Okay.
And then we do the power analysis on the standards for blood pressure. There are different versions out there, but some of them, they say, the blood pressure needs to be within 3 to 5 millimeter mercury of what you're measuring. But then those are all based on cuff solutions.
Okay.
You have to have a device that you put it on, you take 80 measures. The one that we use, it captures a lot of measurements because we're capturing beat by beat blood pressure. But we typically enroll about anything from 30 to 50 participants. The yellow study that we have, we are going up to 250, and that's for hyperintensive patients.
Okay, thank you. And the other question I had was for Heidi. What econometric models were you using to assess volatility?
So we were just using, basically we were using random forests and we were transforming the variables into coefficients of variation when they changed. So it wasn't one specific model. It was just, that is what
I didn't know
we were
whether
doing.
you used Arch or.
Yeah, no, it's a very fair question. It was just a label I assigned to it.
So the audience can actually just ask the question without going to Slido. You have the microphone here, so go get crazy. So if not, let me just tease. Good, get.
So for many of these discussions where you're discussing missing data or the need to interpolate certain data, so I was wondering, what do you all think are some of the best practices? You all do such different types of work. What are some of the best practices for you all for verification and validation of this? So I guess that where I'm coming from is I previously have worked for the NNSA. And one of the ways that they do this is they use different models, different groups, right? That's very important. So what are the practices that you use in your communities to look at how you verify and validate one another's models? Is that happening, I guess, is another question. And what do you think may need to happen in order to, because especially, sorry, now I'm rambling, but for digital twins, just kind of using that as a case study for a moment, but it's so individualized. But as you start to expand it out to larger populations, I guess, how are you going to try to validate that? So I'll leave it there before I keep going.
Right. So that's a great question. I would say in the medical imaging space, you're always building on what's currently accepted, right? So if someone builds a new head coil that's got 256 channels, you show its performance based on the state of the art that exists before, 128 or 64, whatever it is. And you do that, if you're making images, you have RMSE and you have dice coefficients and you have all kinds of SSIM things. So this is an image-based world, and you show these, essentially as good as, and then you can do more. And so I would say that on the sort of reconstruction side, it's the same thing. I mean, when compressed sensing, speaking about like information theory, when compressed sensing came along and told people in the image space, like an MRI, oh yeah, you don't even have to sample half of the, you can undersample by factors of more than half. People lost their minds, right? But from an information theoretical perspective, it's fine. And so people demonstrated that, and then ultimately FDA approved compressed sensing. So I would say it's a good system, i.e., as good as what's currently there, but it has limitations. I'm thinking about your work where okay, blood pressure cuff, it's fine, but you're talking about a new way of practicing medicine, let's say, and they call it disruptive technology for a reason. It's very disruptive, like it means that the ground truths become a necessary evil. But they don't necessarily accelerate or prove out what you're trying to show. So the metrics get complicated in the healthcare space. I mean, that's a good segue to you.
Absolutely. And, so, I mean, the classic way of validating somebody else's technique is to repeat it, right? And show that it works on a new group of participants. But oftentimes, especially some of the academic work that happens, is that you cannot really repeat that, right? So, I think, and because I'm fairly active in the area of blood pressure, I see a lot of work that are pretty interesting engineering techniques, but then the work might be fundamentally wrong because you're capturing some measures from some physiological models. You combine all of them, you put them into machine learning algorithms, and you get some results, right? I think what needs to happen is it's a function of the end application and what you're trying to do. For example, I'm trying to measure the blood pressure for hemorrhage, right? Again, in the case of hemorrhage, what happens is I lose the blood volume, right? The heart has to pump more blood. The cardiac output goes up. You start having tachycardia, higher heart rate. The vasoconstriction would kick in. I have to mimic specific standards that would look at the corner cases, right? That's really the most important part. We need to have benchmarks that rigorously look at everything that where this thing can go wrong, right? And then the other aspect, which is I'm fairly passionate about this, I think we should try to consider the digital evaluation more and more. It's mind-boggling to me that, when you build electronics, right? Let's say you're trying to place a chip on an airplane. The airplane, depending on what kind you have, might experience either really high temperature or low temperature. On planet Earth, you can put it into SPICE and do the simulation on that, right? We're not using that. We just go all the way to RCTs, which are super expensive. Why should I worry about RCT if I'm trying to check, for example, my image segmentation approach, right? I can do it on a phantom before I get there. So
Maybe my answer, right? Because sorry, you want. Yeah, because we are working very industrialized project, right? So I guess in terms of validation, right? My answer is twofold, right? So one is we did run at a methodology level, right? We did run very large scale simulation, right? To better understand those metrics, right? Make sense. And then when we calculated those probabilistic, right? Information flow and propagation, right? In the supply chain network, right? We run large scale simulation, Monte Carlo simulation, right? To better understand if those metrics, right, how that match, right, to different scenarios we try to mimic. And the other thing is, of course, right, when a real event happened, right, that's the best, validation, opportunity, right? So we do try to do kind of even real time or near real time monitoring, right? So because we also build those data pipelines to pull in external risk event data, right, from third party, right, to our internal system, and then hook up with our platform we build, right, so that we can, almost in near real time, right, to calculate what's happened, and then we can, afterward, right, we can, back validate, right, if those metrics, right, provide, a reasonable, right, recommendation, right, for those kind of different scenarios.
I'm thinking about your work, and your work might basically say, oh, everybody should probably do individual real-time dynamic radon, instrumentation in their own homes. And so because there's better healthcare outcomes, right? But that's a pretty high bar because those machines are not cheap. So how are you? I mean, you must be thinking about this every day. I'm sure you feel that, like, yes, everybody should do this, right? Ultimately, what would be the decision maker? Like, oh, it's a 1% improvement in outcome. I mean, how do you think about this? This is a super hard problem.
Yeah, so optimizing for cost and time versus is that level of specificity necessary, right? And so absolutely, and I don't have the answer, but I think that those are things that we should be asking ourselves, because would I like all the data in the world? Yeah, I mean, I like data, right? But it's not feasible for me to capture all of the data. So as we're designing things, I think we should, again, I think it is a hard problem. We should be asking ourselves all along the way, at what point do I really need this level of specificity? And we should be testing that along the way, because sometimes that level of specificity is not necessary, even though I want it. I don't need it. So how do we optimize for what I can do, what's necessary, and what's the almost minimal viable product, right? What do I need in this space to make a difference?
So I have a question for speaker one, just a technical footnote or question. It's amazing that you are able to implement a image inversion or a transform from the true image to the Fourier space with sparse data. We reconstruct from, and shouldn't be translatable to any type of imaging problem. I'm thinking of CBCT.
Yes.
Let's say.
Yes. So yes, absolutely. And the original the 2018 Nature paper goes into that in some detail. That paper has something like 2,000 citations. A bunch of them are in medical imaging. Some of them are in radio astronomy. Some of them are in other kinds of X-ray, what do they call it? Synthetic aperture radar, all kinds of stuff. So solving inverse problems in general, where there's sparsity in the domain. So that's why we think of, imaging is a great choice. Yes, absolutely. And if you know the forward model, and you have a domain that you're interested in, I highly recommend you play with it. It's a very simple approach, actually. I mean, it's basically just uses essentially the universal function approximator that says, with a finite number of neurons, you can get there. That there's a function, you can subsume a function on a compact set. So yes, absolutely. It works for all kinds of things.
Thank you so much for all of your talks and comments. You've all talked about great ways of reducing uncertainty through AI and machine learning. But I'm curious about ways of reporting uncertainty, especially going back to what you were saying about you might not need that level of specificity. But if you can't get to that level of specificity, or if it's not worth it, Or worst case scenario, you think you're at that level of specificity but aren't. What are different ways that you can report that out so that all the users and people affected by it understand the uncertainty and bias?
I'll pull from another project that we have, so not specific to what I talked about before, but where we're using LLMs to basically classify disease on patients in near real time. And what we've done in that space is build in a deep abstention classifier. So as we're training our model, we're also training our model to learn the uncertainty so that when we give a prediction out, we can say, here's what I trust and what can be coded, and here's what someone else should manually review or question. And there are lots of other ways to do that. There are ways to do a post hoc. There are ways to kind of think about where the uncertainty lies. But I think that is the important question. I'm not going to be certain on everything. So can I identify the spaces where there should be more question or maybe more experimentation on what's happening in the data?
Yeah, I mean, that's a great answer. That sort of touches explainable AI, right? I mean, as a physicist, I'm very happy doing nonlinear regression and I get a chi-square per degree of freedom. And when I use my trained neural network, I get an answer. It kind of makes me like, I don't like it, even though it's super useful. And so, yeah, error maps and things like that, uncertainty maps. We did have this project with the so-called local Lifshitz quantitative metric. That's often a measure of stability prior to being deployed rather than something that's used in real time. But yeah, it's a great question. And if these tools didn't work so darn well, we'd never use them because they have this sort of like, we start having to use squishy words to talk about, other uncertainties, but they're right a lot of the time.
And one quick comment I want to share, and I like to borrow it from the notion of generative AI and large language models, is that, generative large language models, in principle, they operate based on transformers and they understand tokens. And tokens are all about correlations, right? It's notoriously hard, impossible to incorporate first principles into transformers because first principles, like physiological models, they deal with causation. Transformers don't understand it. One of the approaches that the literature has started looking into is if you want to combine these two and use the notion of generative AI to extract information from literature that is consistent with the rules and laws of physics, is they focus on prompt engineering, right? They also focus at the output, they call it constraint decoders. They focus on hallucination, right? But the idea is they are thinking about these virtual agents whose job is to make sure the model is correct. The virtual agent is looking at everything, right? I think we need to be thinking about those virtual agents also in the context of uncertainty and look at it from different angles to be able
Kind of like a Monte Carlo. Like the agent is basically Monte Carloing the model, looking for the spread of outputs or something.
An agent should
But
be
the parameter space, unfortunately, is like 10 to the bazillion rather than, a countable number of parameters.
Of course.
So the agent would be like functioning like a GAN.
That's right.
Yeah, exactly.
Go ahead, Igor.
Sorry, it's a quick question. So for the second speaker, for the physics-informed neural networks, I think it's very exciting. It sounds very interesting to integrate this mechanistic knowledge. And for me, it's completely new, so probably my question is naive. But I'm just wondering, suppose the physics system is some kind of differential equation system, which can be solved only numerically, presumably. So how do you calculate that loss function? Do you have to go through all those calculations, or do you approximate somehow? And also a second part of the question, presumably the idea to train the network is not just to save time, to make it a quicker solution, but also that it will discover something more that maybe the mechanistic model was missing. Yeah, thank you.
Yeah, that's a great question. Actually, on both sides, some of these PINNs are being used to also for discovery of new rules that we can incorporate. And the discovery of new rules doesn't mean we need to discover physics. What that means is we need to be able to determine the hyperparameters of that. If we don't have the hyperparameters, we just know the theory of it. So that's the second question. And there is some really good work in that area. In the area of health, it's a little sparse still. If you're curious, you're welcome to take a look at, I edited actually a collection on a digital twin for precision health recently as a part of NPJ, Nature Digital Medicine. We have some really good papers there, but they're going in that direction. Your first question is it's iterative, and you go through, you can start with a base parameter, and based on the data, you start refining it. And the base parameter selection is also an interesting part. Again, what I showed you was a simple Windkessel, but if you think about like a multi-physics, multi-scale model of the heart, we're going to have to go into literature, LLM, to figure out exactly what, because it's more of a grid search, right? It's a brute force search. You start with some, and then you start moving in different directions.
But if you have your differential equations, you can write them explicitly as a computational graph.
That's right.
And it's no problem. So you put that right in there, and then you can solve them. And then depending on what your loss function is.
You can put the PDE and ODE at the last.
Like no problem.
Yeah.
Yeah, you were using actually Navier-Stokes for some modeling, right?
This was the work that I cited.
Right.
Yes,
right.
that's right. Yeah.
Yeah, thank you.
Yeah, sure.
But it's conditioned on you having that information and that knowledge, right? So I think this is the part that I think is questionable with some of what we're doing or talking about in the digital twin spaces. Tell me how these things are really working on a multi-scale level. Tell me how the biology is working, because there's so many unanswered questions in the biology still.
That's a really hard question and hard problem. That's right. And that's why somebody like you, absolutely. Because, it goes really at the level of molecular level, to the tissue level, to the organ level, to the organ system level. Like my passion, I asked that question during the last session, is that when you offer a medication, the medication is manipulating the molecular, right? It's ADME-tox kind of simulation, right? When would be a time that we can connect those ADME-tox to this multi-scale physics that would go to the organ? This is what the literature reports. In cardiovascular health, 40% to 70% of medications are either not effective or they are just minimally effective, only because it's all guesswork. But those are hard problems. So you're absolutely right.
Go ahead, sir.
Just to follow up to Roosevelt comment with regard to trying to explain the laws of physics or whatever theory there is with respect to the subject you're addressing, you might want to ask yourself, to what extent does your theoretical development encompass all the theory concerning that particular subject? That would be another metric that could be used.
That's absolutely right. Yeah. They say, again, I mentioned that all models are wrong, some are useful. What fidelity of the model you need? And then going back to this is that our objective, we understand the theory of it, but the objective is to personalize it. Like Guyton model has been around since 1972, right? Yeah. Yeah. And this would go with the right models. This would go actually and feed our knowledge about what should be the baseline. Again, this is a World Health Organization clinical practice guideline for blood pressure. They have these magical numbers, 140 millimeter mercury, that is considered high blood pressure for all of us. How is that possible? Right? For hemorrhages, they say mean arterial pressure above 65 is good. Below 60 is bad, right? there might be a wounded soldier and the mean arterial pressure is 70, but it's declining fast, versus somebody who has a mean arterial pressure of 60, but it's stable. So we really also need to be rethinking about that notion of baseline. The computational models would help us. That's fine. The reason continuous glucose monitors, in my opinion, are so effective, in addition to the fact that it measures glucose and its ISFIT technology and all that, is that I'm not interested in figuring out what my glucose level is now. I'm interested to figure out where my glucose level is going to be 30 minutes from now, because I can take an apple, right? That's the kind of medicine that we should be thinking about. I'm not a doctor.
No, I mean, that's exactly right. I mean, you want to maintain homeostasis.
Yeah.
Like you don't want to do this, right?
Yeah.
And I think that's true for a lot of things.
That's right.
Great discussions. Any other question? Opinions?
Or do we have during the panel? So do you have any questions to each other?
I mean, I'll ask something. So I'm going to go back to the digital twins and uncertainty quantification. What are your thoughts on how we deal with the propagation of uncertainty as we are moving in a multi-scale space, right? So I have uncertainty at the cellular level, I have uncertainty at the tissue level. What are the right ways to deal with that?
Well, if this was the old days, we'd know how to propagate that error, right? Yeah, right. Yeah, now it's a totally different thing. I mean, so the best we can hope for is that those errors stay in their lanes and they don't like propagate out through everything. But you could imagine if you have, let's say you have several networks that each operate at a different scale, and some smart graduate student says, I'm going to do it all end to end, right? For reason whatever. Now those errors could be entirely different from what they were in their individual local minima of operation. So that's just a statement. That's not an answer, but it's definitely, it's not great that the way we have to probe these spaces is by testing. And it's fine if you work in spaces where I am, where like we understand the sources of the error, so we can do synthetic data all day long. It's fine, but it's different for healthcare outcomes.
And this is a bad answer, but I think one other opportunity, Heidi, and you are very much also in this space, is that we define the value proposition for the solutions that we're trying to build. We identify the corner cases, and we try to focus on those specific corner cases and do the error propagation for those. Again, going back to the example of the blood pressure, there are two different types of medications that cardiologists would typically prescribe. One would make the arterial wall more relaxed. The other one would manipulate the amount of blood volume, right? Depending on what medication the person is taking. And the objective is to figure out if the medication is helping individual to stabilize the blood pressure and the half-life time is acceptable. I think we should be thinking about the corner cases and then focus on those and try to quantify that. And if there are gaps, then we try to fix.
Like the blood pressure case is so interesting because aging populations, everyone's measuring their blood pressure. My father is 89 years old, retired neurologist, and every time a young, wet behind the ears physician sees him, they want his blood pressure to be 120 over whatever, right? He's too old to have his blood. Sorry if he's listening. He's too old to have his blood pressure 120. I mean, it's his vasculature is stiffer than a younger person, and so an experienced clinician can take the same number. Okay, they add one more number, maybe their age, and they make a change in outcome. Properly, measuring those things, like systems you're talking about, where you get a parameter that's more reflective of the end point, I think is really interesting, and definitely like where we should go. Personalized medicine isn't just like a nice thing to say. It actually means that we get a better picture of the individual person and can treat them appropriately.
Let me play a matchmaker among our panelists. Speaker 2, Rosby, mentioned that the basic assumption is that the measure of the arterial pressure is through the stiffness, right? Properties, and that eventually you infer that the heart pressure, blood pressure is indicative of the health of the heart as well. And I was wondering, well, in MRI, one can measure the elastic properties of the heart. So I wonder if low dose or low field MR could help out in this data.
So cardiac MR is so interesting. Typically done at high field. They have beautiful 4D flow. I'm sure you've seen this stuff. The question is, those amazing results, they still have limited utility clinically. Again, quantitative imaging is still a thing that, like, clinicians, radiologists, or MR physicists like myself love it, but it hasn't quite propagated into the clinic yet. And so I would say, yes, we could do something cool together, but ultimately, would it sit on a shelf, motivating the next generation, or even, let's say the next generation of clinicians to be more excited about quantitative information for healthcare is a challenge. We wrote a day one proposal about this very thing, about how quantitative imaging can enable precision medicine. And also, quantitative imaging speaks really nicely to all kinds of AI and ML models. So it's a beautiful world. But again, clinical medicine is gatekept by experienced physicians who have their way of doing things, and doing something new is a shift, if not something else.
And then I'm just going to add one layer of complexity onto what you all are talking about, because some of this suffers from a petri dish problem, where I'm doing experiments in a controlled environment, and then I'm expecting what happens in that controlled environment to be true as soon as I release people out into an uncontrolled environment. And I might imagine a scenario where PM 2.5 exposure might affect something that I'm measuring in terms of my whatever's happening with my cardiac health. And so this speaks to the quality of digital twins in terms of, if everything's in a measured, clean environment, when I try to scale up, do they really work, right? We see this with medicine all the time. In a clean, measured environment, things are great. When you get out into the real world, and how do we solve?
I love that question. And I'm just going to make a quick comment about what you mentioned about the arterial stiffness. So again, cardiovascular system is a closed feedback loop. So many things are happening, right? So the stiffness of artery leads to high blood pressure. The heart has to always work harder. Heart is a muscle, becomes a stronger muscle. Over time, even if you start treating the arterial stiffness problem, the heart now is a stronger muscle. And so the question there is that we want to really understand, and experienced physicians know it. Like, again, when my father sees the cardiologist would not try to match it against 120. They have it in the back of their mind, but we need more qualitative and quantitative tools that would tell us exactly where we are in that cycle. And in terms of Heidi, you're absolutely right. One of the things that, and I don't have a good answer to that question, that's fundamentally correct, but one of the things that we have been trying to do is, as much as possible, understand what the model needs, and the model has to work in a real world setting, real environment. We try to control the context of that model. For example, measuring blood pressure, when I'm sitting here, I might be stressed out. It's not the right time for me to do it. I need to do it at the nighttime. And even at nighttime, nocturnal blood pressure measurement, I should not be doing it at the time of REM, because that's where I'm seeing the dreams. My heart is pumping. I should be doing it when I'm in the deep sleep. So setting the context and building the models and looking at the trajectories is a good one potential solution there.
Great. On that note, it's really an interesting discussion and very, very animated exchange of ideas. I'd like to thank again our panelists and the audience for being a very active audience and makes the whole session really lively and engaging. Thank you all, and we'll see you at the main auditorium then.